into public session and advise the committee that the team. Damien can now invite our guests and witnesses into the room.
It's okay, I was going to say, you don't need to, well, do you want to say anything about it in adjournment when we're in open house?
I will do it at the time, it's fine. Yeah. Imran? Okay. Thank you. Okay, members, welcome to the 33rd meeting of the Public Accounts Committee in this 2022-2027 mandate. Can I advise members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. However, there could be a slight delay moving between private and public sessions, so please be patient with the system. Can I also advise those who are joining us, and most welcome, in the public gallery, that they can use their mobile devices as long as they're in airplane mode and that all devices are muted. And you can connect to the Assembly Wi-Fi. The password is in the gallery rules. It is not permitted at any time to take photographs or record any part of today's meeting or proceedings. We will proceed through our agenda as follows. Apologies, Clerk.
Tom Buchanan.
Tom Buchanan. And online we have Cathal Boylan MLA and Padraig Delargy MLA joining us remotely for today's meeting. If you could both indicate as you want in throughout the agenda. Okay, members, can I? Okay, yeah. Can I refer members to the pack for a copy of the draft minutes of the meeting of the 20th of February at page 7. Of the pack, and can I seek agreements on the minutes, please?
Agreed.
That's great. Okay. Can I ask members if they have any relevant declaration of interest to declare for this meeting? Padraig?
Yeah, Chair, just to declare, I have a few family members who are GPs, and one who's a former rep for the BMA as well.
Cathal?
Yes, Chair, there's one of the presentees that is a practice in my constituency presenting today.
Okay, thank you. And I too would like to declare that one of our witnesses joining us in the BMA is a GP in my local practice in Strabane. Okay, members. Chairperson's business under agenda item 4. I'd also like to welcome to the meeting today, joining us from the Northern Ireland Audit Office, the Controller and Auditor General, Dorina Carville, and Kyle Bingham, the Assembly Support Officer, both very welcome. Agenda item 5, members, at page 20 of the pack is a letter received from Peter May, Accounting Officer for the Department of Health, in response to our letter on the 27th of January regarding the regional procurement of care home beds. Members may recall that on the 16th of January 2025, the committee were made aware of an article in the Belfast Telegraph entitled "More than £600 million in public money spent annually on Northern Ireland nursing homes, never subject to procurement," which was published on the 10th of January 2025. In his response, Mr May outlines the challenges in the procurement of care home beds due to the very great diversity of need in individuals seeking care and consequently very different levels of cost for the support required. Mr May also explains that this is difficult to manage in a procurement contract, and that it is in line with the approach taken across the UK, which is to individually purchase beds rather than the use of competitive tendering. Mr May goes on to state that in the absence of formal procurement, HSC trusts are required to contract for placements at the most competitive rate available for accommodation which it considers suitable for meeting the service users' needs. Are members content to note this response? Okay, members, thank you. Members, at pages 23 of the pack is a letter from the Minister for Finance in response to our letter of the 7th of February regarding the implementation of the outstanding recommendations of the RHI inquiry following the evidence with Jane Brady and Neil Gibson in respect of the major capital projects follow-up report, the Northern Ireland Non-Domestic RHI scheme, and progressing implementation of the public inquiry recommendations second report. Members were concerned that the response from the witnesses in respect of a number of questions raised, particularly in respect of RHA, was that advice was with the Minister and therefore a matter of policy under development, with no further information could be provided to the inquiry. The Minister's response states that the Executive approved an action plan on February 6th to complete the implementation of the recommendations of the RHA inquiry and the recommendations of the Audit Office arising from their 2022 and 2024 reports on implementation. The Minister has provided a copy of the action plan and advised that the Department of Finance is tasked with monitoring the implementation of these remaining actions on a 6-monthly basis. Officials will provide a report to the next board, and the head of the Civil Service will provide the Minister of Finance with a report to issue to the executives. So just before I invite members to comment, could I invite Drina Carville to the table, please? Thank you. Okay, members, any comments on those particular matters around RHA, etc.? Dan?
Yeah, thank you, Chair. And I just will declare that I sit on the Finance Committee also, and I just wanted to bring it to this committee that obviously there was a ministerial statement on the grid on the update of the recommendations of the RHI inquiry this week, and it's obviously gone for information to the Finance Committee pack, and this letter's coming through here. So I think it's important that we just acknowledge there's a lot of recommendations and a lot of actions, and somebody needs to be looking into the detail of them. So we need to decide, are we doing something here or can we release it?
I think that, there has been a bit of conversation in relation to that. I think probably releasing it is the most appropriate course of action to the committee. I know that there is most likely a keen interest to explore these matters. Does members any other views on that? Can we release it at this stage, Clerk, or what's the?
Yeah.
So the proposal is to release?
Yeah. And Chair, and I know, we're obviously keen in this committee, to keep the oversight. So if these are coming out periodically, it would be good, you could keep the periodic reports in our pack in case, you want to look at them, but it's just the detailed recommendations, there's an awful lot of specific actions for the Department of Finance.
Yes.
So it would be good to see the detailed
So release it to the
possible.
Committee for Finance, but also keep an oversight view from our perspective in terms of the quarterly reports. Is that what you're suggesting? Yes? Okay. Members agreed with that action? Yep. Okay. Bring it, Vienna.
Yeah, just to advise the committee, Neil Gibson, the Department of Finance Permanent Secretary, also wrote to me enclosing a copy of the action plan, and specifically asking, which you will see in the action plan, for an indication of when the Audit Office plans to return to audit the implementation. I've responded to Mr Gibson, and I'm happy to share my correspondence with the committee if that would be useful, and commenting on a couple of the recommendations as stated in the action plan, specifically Audit Office recommendations, because there does appear to be perhaps a slight misunderstanding of our role as commented upon in the commitments. We have never and are not tasked with carrying out audits of the full implementation of this. It's very clear that we are and have up until this point been assessing and validating the implementation of recommendations as laid out by the Department of Finance. We also I provide some more clarity around our comments on record keeping in the context of the delays that we found in our work, set aside an RHI inquiry recommendation around having easily identifiable and readily accessible information. And then in relation to that specific request as to when the Audit Office will be coming back in, just to advise the committee, I haven't scheduled any future work in this area, and I've advised Mr Gibson of that. I also note that there are actually two requirements of the inquiry. One is to really look at the implementation of of the recommendations, which is what our two reports have done to date. But there's also a requirement in what we've been asked to do to look at implementation of lessons learned from that scheme. And I note that some of the timetable for the actions is provided in this. They're to be completed at various stages as far out as 26-27. So there is no work scheduled at this point. I will, of course, advise Mr. Gibson when I do intend to revisit that in line with what my normal procedures would be. So I'm happy to share that correspondence with the committee if you think it would be helpful. There are some points of clarification, but clearly there's more work to be carried out. There are new oversight mechanisms in there, and I have indicated that any future work will look at those oversight arrangements provided by the next board and by reporting directly to ministers.
Okay, that's very helpful. Thanks very much. Obviously, I don't need to remind members, but it is important, and there's a public expectation. There's a keen public interest in this particular issue. It did lead to the collapse of these institutions at a great cost to our public. So it is important that we ensure strong oversight and scrutiny that these recommendations are implemented. And I welcome the suggestion by Dorina, and if other members are happy enough, we'll proceed, yeah? Okay.
Just have to forward.
Yes, and is it okay to forward the letter that we have received from Minister John O'Dowd, MLA, to the Committee for Finance? Are members agreed with that?
Right.
Okay, thank you. Thank you, Dorina. Okay, members, at pages 3 to 5 of the tabled papers is a letter from Colin Boyle, the Permanent Secretary for the Department of Communities, in response to the Committee's request for an update on progress on the anti-poverty strategy. Mr. Boyle advises that departmental officials are continuing their work on the development of the Executive's anti-poverty strategy. The Department is currently engaging with officials from all departments to discuss the development of the strategy, which is welcome. A draft strategy is planned to be brought before the Executive in March 2025 for consideration, which is later than what we were told. And this was also raised this morning in the Committee for Communities with the Minister directly in terms of our disappointment. And following the executive agreement of this paper, the strategy will be subject to public consultation prior to its final publication. Officials will provide further updates to the Communities Committee as the work progresses, and an in-person session with the committee has been provisionally agreed for the 27th of March 2025. Do members have any comment? Maybe Colin, have you any comment as Chair of the Communities Committee?
Well, just to say we have shared concerns around the both the timing, I suppose, and the content of the strategy, and it's something that I think we will want to keep a close eye on. There's clearly concerns within the sector that the strategy that's being worked on may not match the expectation that those who are involved in drafting the strategy had. So I think that's something that we will just need to keep both in communities, and I'll declare my interest as Chair of Communities just for that purpose. But I think it's one that we're going to have to keep a very, very close eye on.
I think you're absolutely right, and you know, there's simple housekeeping issues here in relation to the department, because if I'm not mistaken, we were told that we would hear back at the end of January, and we would have a very clear update and understanding where things are. And almost flippantly, the department and said this morning at the Communities Committee that it would be the end of the financial year, as though that was the agreed timescale as well. So it would just be, you know, to remind the departments, I suppose, generally, if they're going to give a timescale, we want them to stick to it. And not have to chase them to get clarification as to why we haven't received the information in a timely fashion, or indeed an explanation as to why it's delayed, which is just good manners. And unfortunately that didn't happen. We had to seek clarification in relation to these matters. Also,
just if I may, Chair, yeah. I think there's actually a slight, even a more concerning difference in that. The commitment to the end of the financial year was to have a final draft with the Executive. The response to this committee was to be the end of January. Sorry, the indication this morning was that response is being worked on, but I don't think we should be waiting to the end of March. That was supposed to be with us by January, and I think there'd be no harm to follow up and to see when we can expect a response back to this committee, because that response is a different item to the final draft of the strategy itself.
I think that's a helpful suggestion, and I think one of the key actions we're continually having to take generally is to follow up on timescales and seek clarification around when actually we're going to receive information. So I think a follow-up to ask when we're actually going to receive that is helpful. and I thank you for that. Also, I think you made an important point, Colin, in relation to the detail, what has been altered, removed or otherwise, and we look forward to seeing some of the information in relation to that. There was also further clarification sought around the partial acceptance of the recommendations and to ensure that the department have a clear understanding of what it means to be the lead department. And I think that the Minister was very clear in saying that he understands the role here, so we'll see. And also, just for information purposes, members, we asked what would appear in relation to this strategy in the programme for government, and we'll all be waiting in anticipation to see what appears when it's finally published, if it is such a commitment. Okay, members, anyone else any comments? All okay? Okay, thank you. Members, at page 24 of the pack is the draft letter. As a draft letter to Colin Boyle, Accounting Officer for the Department for Communities. And members, we agreed last week to issue the follow-up letter raising concerns, and we've brought it back to the committee for agreement. The DFC does not appear to have a role in the mechanism for setting and monitoring targets within the draft anti-poverty strategy. I suggest that in light of the most recent letter received this week, we acknowledge this letter, but that we also do, as Colin has suggested, and follow up, I suppose, in relation to a time frame. That be appropriate, Clerk? Yes.
Yeah, and just to see if members are content with the points made in this letter with those amendments.
Okay. And members, if you could just have a glimpse at the letter, and we will agree it, I suppose. As the members, you'll see it's a letter addressed to Colin Boyle, and I'll read it, and if anyone has any particular issues, just if you could flag. Dear Colin, at this meeting on the 20th of February, the committee considered the response of the 12th of February to the committee's query in relation to the recommendation number 2 of our report on child poverty in Northern Ireland. Members expressed concern that the Department for Communities does not appear to have a role in the mechanism for setting and monitoring targets within the draft anti-poverty strategy. The committee would therefore be grateful for further clarification as follows. Whilst the committee understands that it is a cross-departmental strategy, this should not negate that the Department for Communities has the lead responsibility for developing, coordinating and driving the Executive's priorities for tackling poverty. In view of this, please could you outline what your responsibilities will be as lead department in the monitoring and implementation of targets across departments, and what mechanism will be in place to enable the Department for Communities as lead department to hold other departments to account in respect of the anti-poverty strategy. I think that question is key. Finally, what will be your department's role with regard to accountability for the implementation of targets and its contribution to decision making where there is a draft impact of anti-poverty targets in other departments? So, members, do you agree to that letter?
Yeah, I think it covers it well.
Okay. Okay, members, we are moving on. There is no correspondence for this meeting, and we'll move on now to agenda item 7, which is the inquiry into access to general practice in Northern Ireland, the oral evidence from the Patient and Client Council. Can I refer members to suggested questions at pages 28 to 35 of the pack? And I think it's important, members, just that we keep things as succinct as possible. So we're welcoming our witnesses. Okay, can I welcome to the meeting Maeve Monaghan? Is that the right? Maeva Monaghan.
Maeva.
Okay, thank you. Chief Executive Officer Peter Hutchinson, the Senior Policy Impact and Influence Manager Catherine McElroy, Principal Practitioner for Advocacy. Of course, Dorena Carville, our Controller and Auditor General, is present, and Stuart Stevenson, the Treasury Officer for Accounts. Can I refer members to the written submission from the Patient and Client Council at pages 36 to 58 of the pack? You're all very, very welcome. We're deeply appreciative of your time. Welcome to the Public Accounts Committee, and thank you for agreeing to give us evidence today on this very important issue. So that we can make the best use of our time this afternoon, I asked kindly that you could keep answers brief and to the point, and if at any time you find us interjecting, it's just to keep up with time, it's for no other reason. So thanks very much, and lead the way. Thank you.
Thank you very much for the opportunity to meet with you today and discuss access to general practice. As you're aware, we've provided the committee with a written submission on this topic, which we hope has been of assistance. In building on this, I'd like to share with you a bit more information about the PCC and our role, along with some reflections on our evidence in the current context of primary care and the health and social care in general. PCC are the second smallest arm's-length body in the Department of Health in budgetary terms, but we have a significant mandate from the Northern Ireland Assembly through the 2009 HSE Reform Act to represent the interests of the public in health and social care and seek to influence the system from within. As such, we have a very wide brief and a budget of only 1.8 million to undertake this task, with 34 staff working regionally. As you'll see from our written evidence, within this budget we seek to provide advocacy services for people who have issues in health and social care right across the breadth of those services, as well as engaging the public in seeking to influence policy and systems change. With this budget, that equates to less than £1 per head of population that we seek to serve. Annually, PCC supports about 800 cases and about 4,000 calls from the public. Under the Reform Act, we have 5 statutory functions, and we also have an important independent assurance role for the Minister of Health as set out in the framework document. We're only one of only 2 organisations that have that role, the other being the RQIA. Our independence is something we take very seriously, and we understand this in structural, financial and psychological terms, and we believe that this independence is critical to supporting and encouraging public trust and confidence in the health service. As set out in the framework document, we're funded directly by the Department to maintain that independence from HSE service providers. Structurally, we're governed by the PCC Council, which is unique in contrast to other HSE boards in that the membership is prescribed, but our independence is most fundamentally supported by the psychological independence of our staff. We acknowledge the challenge in this. There is an explicit constructive tension in how the PCC is set up. On the one hand, to represent the interests of the public, and on the other hand, to work within the system to influence change on behalf of the public. As stated in our written evidence, we understand our role within the system of governance and assurance as providing the wider public, HSE trusts and other service providers and the Department with information, insights and evidence gathered as part of discharging our statutory functions. This includes our role in providing advocacy support and advice on the best methods to engage the public, and is primarily based on direct engagement with service users. It's within those parameters and in this context that we offer the evidence today. Reflecting on access to general practice, the PCC acknowledges the wide-ranging, dedicated and compassionate care carried out every day by committed GPs, multidisciplinary teams and GP practice staff right across Northern Ireland. We also acknowledge the significant pressures that GPs and the general practice system is under, and that addressing access issues will take a significant medium to long-term investment and approach. And many of the factors which influence this are out with PCC's mandate to make comment on. But what we can reflect is what we have heard from the public. Our aim in the written submission was to give the committee a flavour of the experience they've shared with PCC about GP and primary care services in Northern Ireland, including the issues and challenges they've faced, the positive experiences they've had, and areas for improvement. In contrast to NISRA data on GP complaints, which shows a downward trend, PCC cases and contacts relating to GPs annually has remained relatively constant, with an increase of 70% from 2022 to 2023. The issues of concern to the public have also remained relatively consistent. The PCC engaged directly with RCGP&I, BMA and representatives from the voluntary and community sector in relation to those issues throughout 2022. We've spoken on these issues at the All-Party Group on Older People in 2024, and most recently sought to inform the Departmental Access Working Group on GPs. In reflecting on the information in our written submission and what the public have shared about their experience of access to GP services, what emerges is a patchwork of experience, a lack of consistency in patient experience, a lack of consistency in what the public can expect, and a lack of patient experience data with which to analyse both what is working well and what could be improved. We note and welcome recommendation 8 of the report by the Audit Office on access to general practice in Northern Ireland, published in March, which encouraged the Department to consider what actions it might take in the shorter term to improve patient access to services, including patient experience of access and services. At PCC, we believe that patient feedback and experience is a tool for intervention. In considering improvements in the short to medium term, a key question, therefore, is how do we know about patient experience of GPs and primary care? How do we collate this information across practices and regionally for intervention? And how do we encourage a more active partnership with the public to support dialogue about service experience and delivery? We think a number of systemic changes would help, which apply to this issue as much as it does to the broader health and social care system, and would benefit both the public's experience and outcomes of the health and social care system, but also improvement within the system itself and the experience of those who work in it. These include consistent and accessible mechanisms for gathering patient experience across GP and primary care services, along with the better use and triangulation of data and insights across health and social care to learn early and drive improvement. Secondly, promote an open and honest dialogue with the public as partners in their care, including harnessing the potential of digital. The need to take a more strategic approach to public participation across the health and social care service, including GP and primary care services as a critical partner in this. And finally, developing a regionalised approach to advocacy services to ensure that people who need support to access health and social care or resolve issues in relation to it get the support they need, because fundamentally advocacy support is particularly important to help address health inequalities. In closing, I would like to acknowledge and thank members of the public who've shared their experiences about GP services with us to enable us to give this evidence today. We're happy to expand on how we think practically and strategically these systemic changes might help, and to take questions on the statement and our written submission. Thank you.
Thank you very much for that presentation and for the honesty that came across in that presentation in terms of some of the issues that we as public representatives are hearing about on a daily basis. So thank you for that. And also thank you to you and your colleagues for the work that you do in difficult circumstances. I suppose I should declare an interest as someone in public life that has referred a number of constituents your direction for assistance, and I want to thank you on behalf of my constituents for the work that you do, the important role that you do. I'm going to start with a question, and then I'll lead with my committee colleagues to follow, and we'll go from there. But thank you for that opening presentation. So how does your council gather evidence on patient experience in general practice, and what are the main issues in general practice that patients contact you about?
So I'll maybe start with your first part of your question and refer to my colleague for the second. So the people can contact the PCC through a range of options. Most ordinarily that happens directly through our free phone line, which we operate Monday to Friday. We deal with about 4,000 calls, and I think you have the data within the paper which reflects the number of calls we've had in relation to GP services. People can also walk into PCC offices. We have a number of offices across the board, access us through social media, through our online website, our contact forms there, and through a range of other, we're referred directly via trusts, and we have a range of raising awareness campaigns across the region. In terms of the main concerns, Peter, would you like to speak to that?
Yes, thank you. Excuse me. Yes, so the main evidence we provided in our written evidence statements comes from our case management system, which is used by our practitioners when they're supporting members of the public. And we divide that into two main elements. One is contacts, which are people who we've been able to provide advice and information to in a straightforward way, and cases whereby people need more support and advocacy support, and some of those cases can go on for a number of months or even years. In the top areas that in relation to cases, which is the more involved that members of the public have provided us feedback with, is communication, and that relates to the type of information they've received. We within that include some issues around the callback system and the telephony system, medication, people's changes to medication or feeling that they haven't been given the right medication, treatment and care diagnosis, treatment and care quality, and staff attitude. In relation to contacts, we have slightly less, as you can understand, less information in relation to that, but having done a scoping exercise, the key areas are access to appointments, advice and information relating to complaints, and issues relating to medication, again, would be the top three. And in relation to access to appointments, you can see from the written evidence there, it's a lot relating to people calling numerous times, having difficulty in accessing or gaining an appointment, and difference in booking systems. But I suppose one thing to also sort of point out is that these are not these are what people have told us. They're not sort of they're not necessarily an objective assessment of quality of care or the service that people have provided. And we also have a focus on early resolution and resolving issues for people with GP practices and other HSE organisations that we work with.
That's very helpful, Peter. It's fair to say that the issues that you're hearing about on a daily basis are consistent in nature across the board. Is that appropriate? Consistent in the nature of the complaint?
Yes, I'd be inclined to agree with that, Chair. I suppose in terms of accessibility, in 2024, we had 1,800 members of the public, citizens of Northern Ireland, who contacted the PCC in respect of concerns they had about their primary care and their GP services. And as Peter pointed out, a whole range of reasons for that. But access is definitely one of the highest, I suppose, contacts that we get, particularly people who are complaining about having to try to contact their GP via the phone line. We have particular concerns for older people who may not have the technology required to be able to engage in the telephony system, for example. And while people contact us concerned about that, on occasions whenever we would assess a person to be particularly vulnerable, maybe an older person living alone, we will try and engage directly with that GP practice, because obviously we have a safeguarding concern also in relation to that person. However, we cannot make contact every time a member of the public makes contact with us, because A, we're blocking up the phone line for that GP as well, and the practice managers or whatever wouldn't take it too well. However, we definitely would make contact if we had concerns about vulnerability. I suppose the other access issues that I would want to reflect as well is the actual geographic access to GP surgeries. And I'm based in Omagh, and I mean the number of single-handed or dual-handed GP services in the West in particular that have decreased significantly over the last 10 years. And while there might be on average 3.1 miles to a GP surgery for people in the West, there are pockets of the West where you could be talking 10, 15, maybe upwards of 20 miles to access a GP. The PCC worked directly with a community group in Ruslay, for example, a number of years ago, where their single-handed GP retired, and a lot of effort was genuinely made to try and recruit to that particular position, and that wasn't successful. And they have been amalgamated to Lisnaskea, for example, which could be 10, 12 miles for some people on rural roads with not very good public transport infrastructure in that respect. I suppose other access issues that we encounter as well are from people where English is not their first language, and while they may be proficient in conversational basis, they mightn't necessarily fully understand medical jargon. Unless you're a medical practitioner, you wouldn't. So we have been assisting a number of migrant support organisations to assist them help their clients with that accessibility, in particular ensuring that translators or interpreters are used to help families in that situation.
Thank you for that. It's good to hear from Omagh as well, I should say. Just a very brief follow-up question. In your experience and given the work that you've been doing over the last number of years, have you found the number of complaints to be upward?
The trajectory is definitely upward, even in 2022, which we would probably consider to be the first year out of the pandemic, really. We had about 1,100 calls, and in 2024 we had 1,800.
That reflects there was a 70% increase in PCC statistics of GP complaints in that year, so 70% increase in the cases that were coming to us in respect of GP and primary care. Now that does reflect the overall upward trajectory of complaints or issues coming to PCC generally. I mean, we saw a 42% increase in our cases across the board, but consistently issues of concern coming to PCC with respect to GP and primary care has been about 25% of our overall caseload consistently year on year.
Okay, thank you. Peter, did you want to add to that, or are you?
Yeah, no, I was just going to say that sort of is a reflection of our cases and contacts that has gone up, but as Mewa referenced in her opening statement, the number of complaints being referred or reported to SPPG by GP practices has actually seen a downward trajectory and trend, so there's a bit of incongruity there between the.
I think that's why we emphasise the point about the consistency around patient experience and regional mechanisms for gathering that, because certainly we're seeing a difference with respect to some of that data in terms of our experience.
Okay, well, thank you. Okay, I'll Colin Gildernew, MLA.
Yep, thank you, Chair. And just to thank you, Mia, and your team for the presentation. It is certainly was sobering from the point of view of how small you actually are in terms of that 1.8. I should also declare the same interest as the Chair in that I have referred people on and have some very good experience of individual cases where it's worked really well. I have to say, I think an expanded form of advocacy would greatly assist not only patients, but maybe more critically, the system. Yeah. Because how will they learn if they cannot glean those real experiences? And I think that's something that we need to really get massively better at. Some of the difficulties that people face in this respect, they're multifactorial. Like it can be bureaucracy, it can be a lack of understanding of what's being asked, and some of it, let's be honest, can be resistance. Mm-hmm. And for me, I think that's why the system would benefit from a duty of candour and would empower workers and healthcare workers within that system to give the learning. But that's probably a whole different PAC report, I have to say. I'll come back to the subject, but thank you for the work that you do. So what is your view in terms of the quality of service provided by GPs currently? You have partially answered the second part of my question, which was what are the main areas for improvement? And I note the 4 areas you've set out. But if there's anything else in that respect or you want to expand on that, but what's your assessment of the quality of access to GP service currently?
If I could briefly just mention, I agree with you with respect to advocacy services, and PCC's model, particularly in the last 2 to 3 years, has been targeted towards early resolution, which means going in and working alongside service providers to try and resolve issues early. And we're currently working with the Innovation Consultancy Service to quantify the benefits of that to the system, potentially in terms of the public purse. So perhaps that might be of interest to the committee going forward. Just with respect to your question then, I mean, I think what Peter has said is the information, we work on the information that comes to us with respect to what the public is saying. So we're not saying it's an objective assessment, but it is no less valid in terms of their experience of quality of access. So I think we include within our submission patient experience from the broader regional patient experience programme, and you see within that some really positive experiences. And what I would note though is that the number of those, there's only 68 stories on the Care Opinion platform in respect of GP services across the region. The majority of those are positive. In terms of the quality of experience that people are having, but what they are also reflecting in terms of the stories that they are sharing is the issue around access. So I think it would be fair to say that once people actually get through the doors to be able to see their GP or their multidisciplinary team or the professional that best meets their need at that point, the quality of care is positive. I think it's the access issues and the lack of measuring against demand for that service that is particularly problematic. And one of the things we therefore wish to highlight is, in order for us to drive improvement across the system and to monitor performance arrangements within GP services, how are we able to do that unless we have reliable, consistent and a magnitude of patient experience data with which to inform that? And I think for us, one of the core areas at the minute that we would highlight is that there is a paucity of data with respect to patient experience regionally. It may be that individual GP practices are gathering that experience, it may be that they are doing really good public engagement work in their local area, but there is a challenge for us here if we are wanting to make regional improvements about how we gather, analyse and feed that information into the system at a regional level.
Could we put a bolt-on onto Encompass that could capture some of that data?
I think the potential within the Encompass system and that's why we reference the potential of digital within certain apps that go alongside some of those digital systems offers a really interesting potential for not only how you would gather patient experience but also how you would have that two-way dialogue, because I think as a health and social care system we are often very good at doing one-way communication but not always listening the other way. And so I think there is a potential within Encompass and some of those other MyCare apps, for example, where you could actually both educate and inform the public about changes that are happening, about the pressures that are within the system, about the challenges facing GP and primary care, but also an opportunity to listen to their experiences and make, more rapid improvements as a result of it. And I think in the shorter term, there's lots of potential there.
Thank you. Okay, Colin Crawford, MLA.
Thanks, Chair, and thanks to the panel for your time and for your presentation today. I just want to touch a bit on access as well, and I appreciate you've touched on it in your opening remarks, and Catherine, in some of your answers already. But from a patient's perspective, can I ask, what is it patients are looking for or expecting from their GPs in regards to access to GPs? What does an acceptable level of access look like?
I think the majority of people, Colin, are interested in being able to make contact with their GP via the phone first system that is now in place, and not have that rush to the phone at 8:30 and by 10 to 9 all possible appointments are then gone. And I think the other thing that the people expect is that there is a consistency across the board, because people are able to say, well, my next door neighbour's GP does A, B and C and mine doesn't, and my next door neighbour's GP, I can make contact with them via text and receive something back. So there's that inconsistency across GPs, and I think there's also a public information bit as well for the public to understand. And unless you're working in the system, people probably don't understand that GPs are contractors and that they provide a core business, and outside of that they have no further obligation. So I think it's that initial access is the issue, and I think the other bit is that people in the public still perceive that GPs are not having face-to-face consultations. Now, we appreciate that that is not the case, but there is a public perception out there, and that face-to-face will be offered if it's deemed to be required. But I think the other issue in relation to accessibility is the access to, I suppose, the multidisciplinary team, for example. Only 8% of the population across the region have access to MDT, and there was an initial rollout of that, and that has stopped. So there's vast swathes of the region that don't have access to that MDT, and I think if that was possible within all of the GP practices across the region, that people would have direct access, for example, to physiotherapy, for example, or social work, or speech and language, or whatever the speciality that they require, which would in turn then probably free up other appointments.
If I could just add to that, I think there's a fundamental question for us in Northern Ireland about changing the nature of the relationship between health services and the public. So to your question about asking what the public need, I think we should ask them. I think we need to switch the relationship to being one less of passive recipients of care to one that's more about an active partnership in that care, because what we find in terms of our experience in engaging with the public is that they often actually hold a lot of the very innovative solutions that might not necessarily cost more, but they actually answer that question in terms of what are they actually seeking and how might that service them. And I think that would be an interesting thing to explore, and that comes back to the patient experience piece. I think Catherine's point about just being able to get through, and you can see from some of the evidence we have shared in terms of people's experience, there is an anxiety there about putting more pressure on services, about reaching the wrong professional, or becoming an irritant. I think we need to take that bull by the horns and look at how we shift that dialogue and educate people about the real pressures in the service, because they're here for the long term.
I might add to that there's also, to a point that was made earlier, growing evidence that when practitioners and professionals engage with members of the public and receive positive feedback and learn from potentially less satisfactory care, that has a positive effect on those professionals and the place they work in terms of morale and their desire to do their work, and also learning to improve services. So it's a double win in that regard.
No, that's really helpful. Thanks, Chair.
Thank you. Okay, we'll go to Cheryl Brownlee, Cheryl's the Vice Chair of the committee.
Thank you, Chair, and thank you so much for your presentation. It's very, very good. And I've used your services before, and I have to say it was fantastic and really helped the constituent at the time. You've kind of touched on this just in terms of those inconsistencies across the board. So do you see anything within your work in terms of best practice? And if you do see something that is very positive or indeed very negative, how is this communicated and then replicated or addressed?
So The reason we wanted to include some of the evidence from the regional patient client experience programme, Care Opinion, which sits within the PHA currently, is because the bulk of the stories there are positive by nature of the people coming to PCC. Unfortunately, we see a lot of people with issues, and that's one of the challenges. So what I would say in terms of the consistency and how we feed that in, we do produce the information annually, and it goes through to our sponsor branch through the Department of Health, and we do try, as I've set out, to try and actively feed that back in. I think the inconsistency that we're setting out in terms of the patchwork experience of people's reality in terms of GP services also speaks to the part about the ability to share best practice at a regional level. So I think the ability for us to regionally collect the experience of people would both allow us to address some of those issues for improvement, but also identify areas for good practice. I'm not sure we could say more than that in terms of identifying areas of best practice at this stage, unfortunately.
I think also, just to add to that, communication goes a long way to addressing a lot of the issues that people come to us with because of their maybe not understanding, for example, that GPs are no longer doing travel vaccines, for example. Just a very small example of that. But I think communication goes a long way, and we found this particularly during the pandemic when, for all good reason, there was a rollback in opioid prescriptions, for example, and people had been provided with information, but the level of communication proved to be very difficult, and people not understanding and believing that they were being taken off their medication or that their level of pain was being disbelieved, when that actually wasn't the case. But opening up those lines of communication helped, and certainly from my point of view, making contact with GPs on a regular basis. Once communication is established, the issues get ironed out relatively quickly. But it's that communication.
No, communication is absolutely key. And whenever I was researching for this, I had found, I think it was in 2014, the Patient Client Council had conducted their own survey in terms of access to GPs. So it was just if you were able to provide any more details on that, have you conducted any more surveys? And obviously the recommendations from that report, have any of those been implemented, and how was that communication with the Department of Health to react to those?
So what I think is interesting about the 2014 report and then follow-up work that we did under people's priorities in 2022 and then the evidence we're providing here today is that some of the recommendations are very consistent. They are about things around patient experience, listening to patients, how we connect that regionally, the role of advocacy services, identifying the burnout, the very real issue and challenge of that within GP services, and how that can be addressed. So I suppose to answer your question, I think a lot of those recommendations were identified as action that the SPPG and others could take. We are finding that we're still consistently making highlighting the same issues in terms of things that we feel are needed.
No. I appreciate that. Thank you.
Thank you. Happy Michelle. Okay, David Honeyford, MLA.
Thank you. Thanks for coming in. You talked about the numbers, and it's frightening, the increase in sort of complaints. 70% is really a frightening number to be said. But just to pick up on that, on the issues, are the issues that people are coming to you with, are they different? Are they new? Or is it just an increase in?
They're much the same. I suppose the system requires us to, categorise them, David, and there definitely is an increase across the board. The issues to do with communication, medication, access, all of the issues have remained constant. Okay. They just are increased.
Right. And is COVID changed just in the scale since that, or so the actual issues? I'm just trying to pick out that the things that they're coming to you aren't different. It's the same as before COVID, if you like, just the numbers are...
Yeah, so as far as we understand, the top issues of concern have remained consistent throughout, so those tend to be communication. Issues around medication have increased as a theme, but broadly otherwise, it's treatment and care diagnosis and treatment and care quality. Now within those, there are many examples of what comes under each of those categories, and we've tried to bring out a bit of a flavour. What we would say is that across each of those themes, access is still consistent in each of them, so we might look at issues that is raised as a primary around perhaps not feeling they got the quality of care or staff attitude in the response that they got, but often access in terms of actually getting in to speak to somebody is a consistent theme in each of the issues of concern.
Yeah, but if we go back 5 years, just to clarify this out, if we go back, or 6 years now I suppose, the pre-2019 poor COVID, is that access still, it was an issue, it's still an issue, it's just greater, just high? Yeah, perfect, thank you, come back.
Thank you. And just before I let Cathal in, I was referring back to the report under staff attitude. This is a case that concerns GPs, but also other practice staff, including receptionists. So one person reported they were told if you were not happy with the service, you can go to another GP by the practice manager when they raised a query in relation to their medication. Are you picking up that there's a sense of fear in any way within patients about complaining about their GP or the service they receive out of fear of being asked to go elsewhere?
I'm not sure that we could be as conclusive as that. I think what our evidence shows is that there is an issue there about access to GP services, being deregistered, trying to access other GP services, movement between services, which potentially points anecdotally to some issues there. And I think when you reflect on what is interesting to me is the data that the PCC holds with respect to the number of complaints relative to the regional data are very mismatched. And so I think when you look also about what people are asking us about, at times it is, how do I make a complaint? How do I access that information? So there is definitely something there in respect of how the public feel they can raise issues and how that might impact on service provision, potentially.
Okay, thank you. Cathal Boylan. Cathal's joined us remotely. Okay, Cathal, fire away.
Thank you very much, Chair, and I do apologise you can't be there in person, and I want to just recognise the good work of the PCC and thank them for the presentation and their answers thus far. Just want to talk a wee bit about multidisciplinary teams, and just want to ask the Council, have they any insight from patients as to whether MDTs are operating successfully and providing greater access to primary care, or are they just merely a signpost in service? Thank you, Chair.
I suppose it would be difficult for us to know, because if people are successfully treated through an MDT, they're not going to come to us. But I suppose looking at the data and looking at the fact that there's only 8% coverage across the region, it would suggest that those 8% of people are getting access to various levels of professionals within the NHS without having to wait on waiting lists, without having to, wait for long periods of time to access physiotherapy, for example. So therefore you would imagine that people would have a better and more positive experience, that they're being able to directly access the professionals that they need to. And I suppose the premise behind that MDT was exactly that, to allow members of the public to have that direct access, rather than sitting on waiting lists for a long period of time.
I think in preparing for this, we haven't looked specifically at MDTs within PCC data, but what I would wish to draw to your attention is that the Care Opinion platform on patient experience regionally has had some traction in terms of implementing their 10,000 More Voices work within multidisciplinary teams, and that is potentially an area where the committee may find more information in respect of your question, Cathal.
Thank you very much. Thank you, Chair.
Thank you, Cathal. Diane Forsyth.
Yeah, thank you, Chair, and thank you all very, very much. It was really important to us as a committee to get the patient voice in the room in response to this particular inquiry. And I just wanted to ask you, sort of in the round, so you've alluded to it that people are coming to you whenever they've got complaints. So it's just important to understand, how are we capturing what's going well and what patients feel is going well with their GP services. And just to put it forward, as a committee, we're going to be making recommendations to the Department of Health, and I just wondered your overall feeling of how the overall patient voice is being heard by the Department of Health, or have you any ideas as to how that could be improved?
So I suppose in achieving balance in respect of some of our evidence, we have sought to include experience from the Care Opinion platform. So the Care Opinion platform is the regional patient experience programme that is run through the PHA, and predominantly so anyone can go onto the Care Opinion platform about any service in Northern Ireland and talk about their story. And you will note that we have given a number of examples within this paper about examples of positive patient stories from GPs. And as I mentioned, the majority, although small, the number of stories about GPs on the Care Opinion platform, because it isn't rolled out across GP services in general, so it's not in wide usage across GP and primary care. There's about 68 stories in total in the last year there, and of the majority of those, they are wholly positive. That is one mechanism through which patient experience is heard across the region. It is one part of the overall kind of public engagement and patient experience landscape in Northern Ireland, which also includes targeted interventions around personal and public involvement, the programmes that the PCC runs in terms of our engagement platforms that influence policy at a regional level, and then information from advocacy and complaints both within the PCC at a regional level, but then within each of the HSC trusts. I think one of the main points we wish to highlight is I think more could be done in respect of GP and primary care services around actually understanding the patient experience at a regional level, because when you look at the data that we hold, or even referencing the GP Working Access Group of the Department of Health, their report referenced 42 individuals. So there is much more that could be done in terms of how we either harness the patient experience that's being heard within GP practices and elevate that to a regional level, or how we embrace patient experience more broadly in order to, as you say, Dan, both recognise good practice but also understand what's working well and try to replicate that. I think in terms of the question about public engagement in general, one of the strategic priorities and the thing that PCC is trying to drive is that we see a real need and benefit in having a broader strategic cohesion in public engagement in health services. We're very fortunate in Northern Ireland that we have a statutory duty in respect of personal and public involvement. It's been in place since 2009, but I think we're in a different context now in terms of health, and I think there's lots of really good work that goes on regionally, but quite a lot of it is in local pockets. I think there's a need for us to pull that together at a more strategic regional level, to bring that together and to more positively influence service transformation and design. And what we would see as a critical component of that is that change in relationship again, because it works both ways. People are more invested in what they help create. And I think with the challenge facing us in health in respect of transformation of services, it is never more important now that we get people engaged in those conversations at an early stage, that we inform and educate about what those changes need to look like, and that we engage people in those conversations early, because the changes that are coming down the line are more acceptable when you understand what that means, and whenever you experience them at a regional level. So I think more strategic approach to that generally would be very welcome.
Thank you very much.
Thank you. David Hungerford?
Yeah, just looking at in your report, the paragraph 28, and we get a lot of stuff, a lot of things that come through my own office. I should have said that the first time I spoke, my GP practice won practice of the year and are absolutely fabulous. So, but that's because it's that's nothing to do with me, to be honest. But I get a lot of stuff through my office. A lot of complaints we would get would be that first call of the reception and the barrier there. So kind of want to look at that frontline staff, whether there's a hindrance or help, or what way that looks, or what your opinion of that is, to actually act on the basis of accessing GP. Have you any opinions or anything to say around that?
Yeah, I suppose people do identify that as a particular barrier, and whenever we were speaking with the all-party group for older people, we the RC or the GP representative made reference to receptionists being care navigators, which was a new term to me in particular, and I think the public aren't fully aware of that receptionists have the capacity, I suppose, to triage, for want of a better word there. However, I think whenever you're living in your local community and the person taking your call is maybe your next door neighbour or someone you know, you have a reticence to share personal information in that respect. So I certainly think it's one of those things that need to be communicated more effectively and help people understand that their role is not just to take a call, but to be a care navigator. And I think there can be that conflict there.
So how do you improve that barrier? Because that you've nailed actually what the issue we get is this is like my neighbour, I know them from, you know, especially when you come into a rural village in my own area, so they know the person personally, and then they're having to share. So how do you improve? How does that improve, or how does that remove that barrier, if you like?
I think it's communication. I think it's having open communication between the GP practice and their patients, and helping them understand the way their information has to be received into the GP practice, and how that will help expedite matters for them. But I think communication is the key to all of that.
I think there's another aspect to it, which is about providing multiple options potentially, because for some people, speaking to somebody directly might be the most preferable option based on accessibility issues or additional needs or their age, etc. Others may wish to be able to provide their information through digital means, through an app, through the call answering service. So that's one aspect to it. I think looking at different pathways for access would be critical. I think the other aspect, which follows on from communication but is an often lost component of it, is building trust. And you build trust through people understanding why the nature of access has changed, what is going to happen with their information, why this is the particular person that's taken, and whether they've changed from being a receptionist to a care navigator. I think emphasising that building of trust in order that people feel comfortable accessing in that way is really important.
The addition I was going to make was that communicating and engaging with communities and the public to assess and address these issues is a different type of way of communicating and engaging outside your normal area of practice within a GP or a setting potentially, and engaging it with and having participation with the public in this way, it requires commitment and often investment in it. But that means you have to see the sort of what your goal and potentially you're going to gain from it, which we would suggest is better patient experience, better quality of outcome, and also probably potentially a better place to work, because you have a more collegiate approach to how you're delivering services. So it's a different way of doing, which links back to the need to be strategic and look at this in the round as to how we do it in general.
Thank you.
Okay. Just briefly, and we really appreciate your time with us and your answers. You mentioned earlier that there needs to be a shift from passive recipients of CORE to a partnership approach with health providers. Can you expand on this and how it could be achieved?
So I think in terms of, well, first of all, I would say it's a continuum, because there's absolutely situations where being a passive recipient of care is appropriate. If you are potentially in receipt of or your cancer and you're potentially in receipt of treatment, you're more likely to want to be in the passive recipient situation, which is where you are achieving good quality care from professionals in your best interests. I think that continuum and where you fall on it, right through to active partnership, is very much dependent on circumstance. But what we mean by that is an active partner in your care is somebody who is well informed, is able to make informed choices, is aware of the services that are available to them, feels a level of sharing of power in order to make choices about their life that enables them to live a more healthier life, which potentially avoids needing to access services as much. It is a fundamental change in terms of how you partner with care providers in looking at your contribution is welcomed and valued in terms of your patient experience. And so I think one of the challenges we face in making that shift at the minute is the reality of how people are experiencing services in Northern Ireland and health at times is a system that's particularly under strain. People vote and pay their national insurance contributions, and they certainly have certain expectations as a result of the care. But if that's not then necessarily being developed or delivered in the way that professionals would wish because of all the challenges we're aware of, you have a situation, therefore, where people are either accepting of it or perhaps avoiding going to access services as a result. There are others who may be able and willing to buy it, and that's where that drive to private healthcare comes, or there's others who may fight for what their expectations are. There's another choice, which is looking at a more active partnership approach to delivering care and looking to shift towards that.
The other approach is interesting to explore, but are you finding, due to the nature of the situation we face in terms of accessing care, that people are just avoiding doing it, as opposed to, some people can go private. It's not an option available to everybody, as we know, and that's raising serious problems and questions. But are we finding those who are finding it difficult to access care just avoiding going through the process at all? Like in my experience, that people are going, it's not worth the hassle, I'm not doing it, and then ultimately aren't getting diagnosed in time or whatever.
I think that one of the things about a lack of patient experience information is that currently we're not able to assess the experience of those people who don't access care at all. So the information we're providing to you is based on those who've come forward or who have tried to access services. I think what is the most concerning thing in some respects is those individuals who are already potentially more marginalised or outside of those access conversations, and who therefore we simply don't know about their experiences currently. So I think that is certainly a potential problem in all of this as well.
And in terms of getting to those people that aren't sharing those experiences, what more can be done by your organisation generally to reach those people? Not everybody will understand what the patient-client council is or does. In fact, most people are educated on the work of your organisation when they approach an elected representative and we say, well, this is the avenue you could go down. So how do we ensure that there's a greater awareness of the good work that you do in raising those concerns, which applies pressure ultimately, and hopefully solutions at the end of it for people? So what do we do best to support that?
Thank you. So in the last year we have embarked on a raising awareness campaign that has been about trying to explain the breadth of the work the PCC does, because historically it has been known as a complaints organisation, but actually 4 out of 5 of our statutory functions are about engaging the public and advising the system on best methods. Yep. So at the minute we have new promotional materials, animated videos and testimonials from the public talking about those who have used our services that are available and that we are sending out right across all of the trusts. All of the GP practices have recently received them as well. So we're really encouraging any of our elected representatives or any of those who have access to the public to raise awareness of PCC services. The other thing that I would say in terms of the approach around reaching those who perhaps are left out of these conversations is that our conception of a more strategic approach to public engagement is through a network of networks. So the volunteering community sector are touch points every day for people who are coming into services who are being supported in certain ways. We partner with the volunteering community sector and with health service providers to try and access those individuals at their point of need. So 2 examples of how we've been doing that in the last year is our Positive Passport initiative, and that is about ensuring that there is a clear pathway into PCC services and access to support through charitable and voluntary community sector organisations who are working with those who might have a health access need but who are also having other needs met in different ways, so we can partner with them and work in collaboration to make sure that people don't fall through cracks. Because I think when you look at some of the findings from inquiries and other reports, people very much felt that it was a revolving door in terms of being told or signposted to other services. So that's one initiative. A second initiative is we have been citing PCC support in the community within hosting clinics within existing spaces where people are coming to access needs. So examples include food banks, voluntary community sector support organisations where we will show up and if people have an issue they can access PCC support at that point of need rather than an expectation that people would seek out the PCC, because as you say, it's very much the case that you don't access or know about our services until you really critically need them, and at that point it can sometimes be too late.
Sometimes in local and I'll finish this question, but sometimes in local surgeries it's a point of information on a lot of things. I'm one of those people that was reading everything on the wall, but it's has there been any barriers in terms of promoting your service within local GP practices?
Well, we have sent out the information recently, so I think our feeling would be that most services are very receptive to partnering with PCC and to making them aware of our services. Infection prevention control and the move to digital means that people are not very open to having kind of posters in the same way, and that proves issues in terms of people's accessibility. But I do think in terms of the MyCare app and other opportunities, there is a way to reach people and to point out PCC services and other organisations in a different way going forward, and I hope that we'll be able to explore those.
Okay. Has members anything else to add? No? Dorena, have you anything you'd want to? You're happy enough? Stuart?
Thank you.
Okay, these are all well behaved today. Is there anything further you'd like to add for us?
I suppose there's just one thing I would like to add as well, and that is the shared care arrangements between GPs and private practice. And I think as private practice increases in its volume across Northern Ireland, and that patients maybe do not understand that if they access private care, that there is no obligation upon their GP to continue that care, particularly around prescriptions. And we have found a rapid increase in the number of people contacting us around adult ADHD services, for example, where they have accessed private care and private prescriptions, and their GP has not been obliged to continue that. So I think there is definitely an education piece in relation to that as well, that if patients want to continue down a private pathway, the implications that that may have for them. And I think around the issue of ADHD, because there's no diagnostic and treatment pathway in Northern Ireland for that, that has created a huge difficulty for a lot of people.
I'm experiencing that at the moment with a number of people. So thank you for raising that, Catherine. That's very helpful. Can I thank each of you for being with us and for your presentation, for taking our questions and for answering them and sharing the experiences of your organisation. I will say again very firmly, we are appreciative of the work that you and your team do. I am one of the signposts that direct people to you on the occasion that it's necessary, and I know many others do the same. It is an important inquiry, this, and your evidence session is key to it. So thank you very much for being with us, and we appreciate your time.
Thank you.
Thank you
very much.
Yes. Members, with your agreement, because we're going into another evidence session now with the BMA, I think it would be appropriate to adjourn for 5 minutes for a bit of a comfort break if members are agreed.
Yeah.
Agreed. Okay. So I'll see you. We'll 25 past. Okay. Thank you. Where are they?
Senate Chamber. Sound. 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 Senate Chamber. Sound.
Okay. Okay. Okay, members, welcome back. We are now moving on to agenda item 8 of our inquiry into access to general practice in Northern Ireland. This is an oral evidence session from the BMA Northern Ireland and the RCGP NI. Can I refer members to questions in our documents at pages 28 to 35 of the pack? And we will wait briefly until Damien welcomes in our guests. Okay. Yeah. Okay, members, we are now on the next agenda item, and I want to welcome our witnesses for today's evidence session. Can I welcome Dr. Francis O'Hagan, Chairperson of the BMA Northern Ireland GP Committee and British Medical Association NI, Dr. Kieran Mullen, Deputy Chairperson of the BMA NI and GP Committee British Medical Association for Northern Ireland, and also a GP in my local practice, just to declare an interest. Dr. Ursula Mason, Chairperson for the Royal College of General Practitioners NI, Dr. Emma Murtaugh, Deputy Chair of the Royal College of General Practitioners NI, and with us also we have Dorina Carville, who is the Comptroller and Auditor General from the Northern Ireland Audit Office, and Mr. Stuart Stevenson and Julie Sewell from the Treasury Officer of Accounts for the Department of Finance. You're all very welcome with us today, and we deeply appreciate your time and your presence, because I know how very busy you all are, so we do appreciate you being with us. Can I refer members of the committee to the written submissions from the BMI that's been kindly provided at pages 60 to 82 of the pack, and from the RCGP at pages 83 to 91 of the pack. You are all very welcome, as I've said, to the Public Accounts Committee to give evidence today. And obviously time is of the essence, so I'd appreciate if the opening remarks could be brief. Members will have questions, and that will allow for further conversation. If you find any of us interject at any particular time, it's supposed to take the most out of this session as opposed to anything else. So with that said, thanks again for being with us, and I welcome you to brief us. Thank you.
Well, I'll kick off and then Ursula will follow me. So, good afternoon, committee, and very welcome for this opportunity to come and advise you on access and general practice. My name is Dr. Francis O'Hagan. As I said, I'm the chair of the Northern Ireland GP Committee. I'm also a practicing GP and a partner in Armagh and the Friary Surgery. With me today is my deputy, and I'll let Kieran introduce himself.
Yeah, I'm Dr. Kieran Mullen. I've been a practicing GP in Strabane now for 23 years, so I've been Francis's chair for the last 6 months.
So you have received our briefings, and I would like to outline our position to the committee prior to the questions. While Ursula and I will sing from the same hymn sheet, the BMA is distinct from the Royal College is that we consider on contractual matters, and Ursula will then go through her stuff. So access to general practice is the issue that you as LMAs will receive messages probably every week about. It affects every citizen in Northern Ireland, including all of us. We are all patients as well. We thank the committee for their interest in this. General practice is in crisis. Contract handbacks represent the most visible indication of the crisis that we're in. As of March 24, there are 312 active GP practices. This is a reduction of 5 practices in the previous year and a reduction of 38 practices in the last 10 years. That's 11% of our practices are gone. The situation is untenable in 2024, and without a solution, it's going to get worse. The other thing to remember is the population has increased by 70,000 in the last 10 years, whilst we've lost 38 practices. Access to general practice is something we continually hear a focus on. And the Health Minister also has a focus on it, but there has been no commensurate upturn in funding to enable this to meet the current demand. Despite this, and contrary to popular belief, we believe that there is good patient access for many patients in place. In fact, the GPs have significantly increased our patient consultations. In 2022, as we emerged from COVID, GP practices saw 9.7 million consultations. Last year, this rose to 10.1 million consultations. That's a 5% increase with a decrease in doctors. Now, just think about that. 10.1 million consultations is that each week general practice in Northern Ireland delivers over 2,000 consultations. That's 10% of the population see their GP every week. Think about that, 10%. That's a lot. The other thing we need to mention is that in 2024 we saw the majority of the consultations back to being face-to-face. Well over half are back face-to-face. So this idea that we're closed and doing nothing and nobody can get a face-to-face, the figures don't support that. Access to general practice goes a long way beyond just getting the phone answered and seeing a doctor. Included in your briefing pack was the infographic of the iceberg. So I think that is a very important infographic to look at, because everything below the surface is also access that we do. So for example, if I look up your blood results and I comment on them and I give you a ring to say, you know, you need folic acid or something like that, that is access. If my nurse takes you in and does your diabetic review or does your smear, that is access. You know, if I read a hospital letter and on it the hospital want me to do something, I have to contact you and get you in. That is access. All those things, all the paperwork we do is access. If we're doing a solicitor's letter for you or we're doing a life insurance report, that is access. So access is not just answering the phone or getting a face-to-face appointment. And that's really important that that's understood. There remains much to do. This needs to be enabled by investment from the department, and we believe the best way to improve access would be for the department to focus on investing in the GMS contract. GMS stands for General Medical Services, and this is what we call our core contract. And this is a standard contract to deliver the core services negotiated between ourselves, NIGPC, and the Department of Health. It's the BMA's position that there should be at least 10% of the health budget spent in general practice, considering we're doing 95% of the consultations. That's not a big ask, and that's what it was when I first started in general practice. It's now 5.4%. So with 5.4%, we deliver 95% of care. That needs to go up if you are going to expect us to do more. And if the Minister wants to shift left, then he needs to shift the resources with it. And by the way, that's the lowest investment in general practice in any of the 4 nations. It's simply not enough to deliver 200,000 consultations a week and keep going. General practice will always be best placed to be the first point of contact for people, and we should aspire to continue that. But with the desire to shift left, which we wholeheartedly agree with, we need to move the funding. In the first instance, we're asking the Minister to increase our core funding by £40 per patient per year. That's 80 million. Out of a health budget of 7.8 billion, that is merely 1%. That's all we're asking for, is 1% to start to get us back to where we need to be. I'm often asked by MLAs what general practice would do with 1%, and I'm happy to answer that. I can assure the committee that every penny will be spent. The spend will vary from practice to practice, and we heard that there's not consistency among practices. So there are practices who have got very little GPs, very little staff, very little nurses. They would be investing in those members of staff. There are also practices who, the patchy about MDTs. So there are 10 federations in Northern Ireland have no MDTs. So we would be investing money in that as well. But an MDT doesn't work if you don't have a doctor there to supervise it. The overall additional funding will begin to progress the stabilising of practices. It will also give GPs confidence that the Minister is listening, that general practice is valued and places its belief in the Minister understands that shifting left means reconfiguring how finance is allocated. Costs are increasing rapidly, and the increase in national insurance contributions is also going to be immense if we're going to have to shoulder that. That's a significant cost we just can't afford. And literally, ideally, we would want the Treasury to ensure general practice is exempt, but failing on that, we call on the Department of Health to provide the additional funding, and it be a reimbursement on a recurrent basis. If that doesn't happen, we will lose staff and access will reduce. April is fast approaching. We need an urgent solution. Without that, we have unfortunately looking at cost cutting because we have no other way of bringing in the income. I'll speak briefly about indemnity. We are currently in a round of constructive negotiations with the Department. Resolving this is a key for our members in Northern Ireland, as we are the only GPs across the UK who pay for this ourselves. And we believe the Minister has taken our indemnity seriously. On my final point, the importance of MTDs to provide stability in practices and improve access to equitably meet the needs of our population can't be understated. MDT rollout needs to be prioritised by the department and funding of the rollout to be regular and recurrent. At the minute, we only have 7 areas, 7 out of the 17 that have MDTs. But I go back to the point, you can't bring in an MDT unless you have more doctors. And before I finish and take questions, I wish to reiterate, as GPs, we are doing the best we can with what we have. But we need to see a recognition from the Minister to increase our funding. The GMS contract for 25-26 must include solutions for both indemnity, national insurance and a modest increase in our core funding. Anything else, I am sorry to say, will result in further practice closures and contract handbacks. Thank you.
Thank you, Dr. O'Hagan. You've answered my question completely, actually. You haven't left one part of it. I was about to ask, is GP services a state of crisis? I think the obvious answer, given your opening remarks, is yes. And I was asking what your current view of the sector is, and you've answered that. And I was also asking what's going to be done to fix it, and you've answered that. So we're on the one page, which is a good starting point in recognition of the very serious problem that there is. I think it's very clear to us all that there is a problem, and I think a lot of this is about how we communicate that problem and how we find a solution to address it in the interest of our people, patients, and of course in practice generally. I have to say, when I looked through the very detailed briefing, I was alarmed at the figures. We don't always realise that there's been a significant increase in the population, but a drop of 38 practices as an example, which is a very blunt statistic in alerting our attention to the issue that we have. And equally, that there's been a 5% increase in the level of demand on the services. And further to that, 10% of the population see a GP every week is also alarming. But further to that as well, the funding issues, and you've talked a lot about funding, and the ask isn't huge, 1% I think is what you've said, just to clarify. I was looking at the figures in terms of England. They're looking for 15%. They're sitting at 10%, and Northern Ireland is sitting at 5.4%. Isn't that correct?
Yes, and 10% is our minimum.
Yes.
We would aspire to move to 15%, because if more work is moving, then we need to fund that work.
Okay, so my question really is, if there is no increase to the current rate of funding to GP practices in Northern Ireland, what will be the impact over the next couple of years?
More practices will close and access will reduce, because we just can't keep going if we're not funded to keep the doors open. How can we actually stay open? We have practices who are teetering on the brink. The national insurance thing is massive. If you employ a lot of your staff, i.e. especially if you employ your doctors, which the MDT practices do, and they could shut overnight. Kieran's an MDT, you know how many practices are there under the CICs?
And that's the emergency measures that kind of kicked in with practice closures in terms of trusts taking them on and federations taking them on. That can't be sustained, that won't be able to be sustained. So if you don't have the model of funding going into core general medical services to allow people to maintain the independent contractor status, then you will run out of the emergency provision, which has happened now in the last while. And again, the MDT model is so critical, but what it has actually done, it has created more inequity across Northern Ireland in terms of practices that have MDTs, practices that don't. So therefore it creates more issues. And as Francis has alluded to, if you do not have the critical mass of GPs within practices to put an MDT around them, then it won't work either.
Yeah. I got carried away with your briefing that I forgot to ask. I forgot to ask for your opening remarks, but it was because everything that you had said drew my attention. So thank you to Dr. Mullen and Dr. O'Hagan for that. So I welcome you now to the brief opening remarks as well. Thank you.
Thank you very much, Chair. And you'll not be surprised, we do all sing from the same hymn sheet, so there's nothing that Francis has already said or even you have made comments on that we'll be arguing about, and I will keep opening remarks brief in the interests of questions. My name's Ursula Mason. I'm Chair of Royal College of GPs in Northern Ireland, and I'm a GP partner in South Belfast and have been for over 20 years. And I'll let my colleague Emma Murtagh introduce herself.
So I'm Emma Murtagh. I'm a GP in East Belfast.
I'm going to probably touch on a few things that Francis has spoken about, but I'm going to start with what I was going to say last, because actually GPs want what patients want and what they actually deserve. And what they deserve is good access and a free at the point of need NHS general practice, not us firefighting every single day with urgent demand, with our limited capacity. And we're very much constrained in our ability to do what we do best. Because as Francis said, there is a crisis in general practice and all the signs are there, and you know what they all are. They're the contract handbacks, they're the inability to recruit. A third of all practices in Northern Ireland have accessed crisis support in the last 3 years. The underinvestment and the inadequate workforce planning mean that we obviously have the fewer number of whole-time equivalent GPs than we had a decade ago, but that population increase is there and the need is there. We have an older and an ageing population with more long-term conditions. We've the spiralling waiting lists that aren't coming down, and sometimes and more often than not, the only people that those patients can access are GPs. So the demand is outstripping the capacity and it continues to rise. So those 200,000 consultations every single week aren't enough. Yet that's what we're being funded for. So we are getting what is being paid for, and we are struggling to maintain an ability to deliver for all our patients in a safe and equitable way. That pressure is there, it's outstripping capacity, and it's adding to GP burnout. It's adding to our recruitment crisis, and that shift left keeps pushing and pushing without the investment and without the funding to meet it. But we want to be able to deliver good quality and timely care to patients. We just need the resource to be able to do it. And we are currently doing more and more with less and less, and we are at crisis point because that cannot continue. So Francis asked you about what access would look like for you, but I'm going to compare access to other parts of the system, because every part of our NHS is struggling with access. The 8:30 a.m. scramble on the phone each morning that we hear about patients having to endure, that's our equivalent of crowded emergency departments. It's also the equivalent of red flag waiting lists in the hospital sector. For the countless people who can't get through on the phone or who are told, sorry, no more appointments, phone back tomorrow, emergencies only, they're our equivalent of the ambulances stacking up outside EDs, and they're also our equivalent of those ever-growing routine waiting lists. It's difficult to quantify what that demand actually is, let alone film it, but it's there, and many of your colleagues in the Health Committee have come out and seen what it's like on the ground in general practice with us over the last few months, so they know what it's like. Our problem isn't flow, it is capacity. And sometimes we conflate access with capacity. We don't have capacity to deal with the need that's there. And it doesn't matter how many phone lines we have if we don't have a call navigator at the end to be able to direct that call, or importantly, a GP to see a patient when it's needed. But our GPs are working regularly beyond safe limits every single day, fitting in the extras, doing another house call on their way home, staying late again and again, and sustaining this is compounding the burnout. It's compounding the issues that we have in terms of recruitment, and it's not good, safe patient care. It's that more and more for less and less again, and we can't continue to do that. But we really care about our patients, and we're really worried about what we might be missing. Where are those additional red flags that we're not picking up? Where's all that ill health that is being contributed to by us not being able to meet today's need today? I know the Audit Office had set out the need for a GP workforce being vital if we want to start tackling capacity issues, and those capacity issues frustrate GPs as much as they frustrate patients. But GP recruitment numbers have stalled, and actually we need to go from about 121 to 161 incrementally over the next few years to get to the point that we were in 2014. That's not to increase numbers, that's just to get to where we were. So we're actually lagging behind, a decade's worth of lag there. And in April last year, the college released a retention strategy with solutions to keep GPs in their jobs, because they're leaving, they're quietly quitting, they're burning out, they're retiring early, they're not even taking up posts after they've qualified because of the situation here. Our strategy came with a health warning. It wouldn't be worth the paper it was written on without significant additional investment in general practice and a work plan that was fully enacted and resourced. Neither of those have happened. MDTs have been cited as a key element of transformation, and by all means they are really important in primary care, but they're not happening fast enough and they're not happening equitably across the region. And though that increase is welcome, it won't solve the crisis in general practice. They will create a degree of short-term stabilisation and they will create a little bit of access in primary care, but they are not a silver bullet, not least because of the inequity that currently sits at the minute. As Francis said, funding of MDTs should not and cannot be at the expense of ensuring core services are adequately resourced and sustained. Without that robust core, where you've got medical generalism delivering whole person, whole of life care, a model of MDTs wrapped around that will not actually deliver for patients. And when it comes to contract handbacks, I mean, most GPs, when they hear a contract has gone back, their head's in their hand thinking, who's going to be next? Is it us? Is it our partners down the road? And that's not to even consider what patients think about when a contract goes back, because they're thinking about, will I lose services? What will happen to my practice? What will happen to my care? They're a signal of chronic underfunding and recruitment challenge. They are not a signal of failure, but they do raise the red flag to the system. Something needs to change.
Commission, the briefing is very detailed and very good. I'm just worried that you're going to leave us with no questions.
The one thing can I say is if you invest in general practice, and this will be my final comment, we know that there is a very well rehearsed benefit for investment in general practice. For every pound that is invested in general practice, there is a £14 return to the economy. That is the single biggest return right across the whole of the health system. So if we think about Francis has asked for 80 million, imagine what will come back to our economy if that gets invested in primary care and not in somewhere else in the health service. And I will end there.
Thank you. I'm sorry for cutting across, but genuinely you'd answered my question, and then I was going, if they've answered my questions, then I've answered others. So I just wanted to, but I appreciate that very much, and for your honesty in terms of your opening remarks. Before I pass to my colleague, Jan Forsyth, I just want to touch on the funding issue again. Just to be clear, the 1% request, is that simply to even things up and stand still?
Yes.
Okay. What would return GP services to where they were in 2014, I think was the year that you had said, probably is the best example, in terms of
something between 10 and 15%.
10
to 15%.
10 and to 15%. The reason I've asked that question is when I'm saying that England is sitting at 10 and they're looking for 15, and we are significantly, almost half behind that, I just have some concern as to what it's going to require to even catch up.
I think the example of what happened in Wales this year is nearly easier to log across, because we're 2 million approximately of the population, they're 3 million, and this year, in year, not even talking about what I want for next year, they got 51 million this year, in year, because of the recognition of how defunded general practice is there, and they're better funded than us.
Okay.
I think one of the things to consider, though, is that incrementally, as you increase funding, I mean, 1% keeps the doors open and the lights on, and it keeps, creates a degree of stability. But actually, what we need to do is to grow services and to make sure that that shift left can happen in the most appropriate and safe way for patients. So those additional or incremental percentage points where you're moving from 5% up to beyond 10% is actually delivering really good service for patients. So it's about making sure that we have a workforce that can do the job, that can create the care for patients when they need it, as well as actually thinking about the aspects of infrastructure, about the wider teams, about bringing care into the community. So, I mean, when we talk about moving from 5% to beyond 10%, it's about actually restructuring the whole service to have a lens that faces into the community. And that's what you would get for the money beyond the 1% that Francis has talked about. So this is about creating a much more stable and effective general practice within a wider primary care setting.
If there were, and I know I'm holding up time numbers, but I'm just conscious of where things are at. If there was an increase to funding that even exceeded the 1% request, just say it was 2%.
Happy days.
Would that have how do you feel, what would the knock-on effect be, for instance, to the numbers of people headed towards the emergency department that can't get access to a GP, for instance?
Well, if you look at the figures for currently, or what last year, what was provided, so in year GPs provided 10.1 million consultations, ED provided 675,000 in last year. So I think it would be looking as to what, if we got additional funding and more resources and we had more GPs, you would get past the status where GPs an endangered species and start to see that we have more GPs and provide more care in the community, and start facing things from hospital back towards us.
And just to add to that quickly, the disparity that you're pointing out in terms of England, Wales, now and the other 4 nations, we also have that disparity now into the Republic. So in terms of the message that would send, that 1%, 2%, in terms of retaining a workforce, if you have a medical graduate, if you have somebody going into GP training, where they see that a department is taking general practice seriously, primary care seriously, where the Minister has targets around shift left, and where basically it's funding is following that, then you are much more likely to retain a workforce, attract a workforce. Otherwise, they will move to the other 4 nations or go down south or further afield, as they're doing at the moment.
As is happening, I was about to say. Just final, very briefly, I think, by the way, one of the terms that I'll carry away from this is GPs being an endangered species. That is hugely alarming, but probably very, very accurate. Which of the 4 nations would you say is best practice? I know there's issues across the board, but where would you see that they're doing it well?
The issues are different in different areas.
Yeah.
Our contract in 2004 was the same across the 4 nations, but the core contract has remained the same, but the bits around the edges have changed in the different areas. So we, in England, they still have some QAF. We have QAF now in our core, but we still do the work. So to get quality, you're going to need patients need time, and if you're going to do that work that we're currently struggling to do, which is your preventative work, which actually saves money down the line, that's where quality comes in, and you're able to actually then say, I'm able to spend time with this patient rather than rushing them in and rushing them out and taking work home at night and doing your bloods at night. It's about time and resources. We'll be able to feed that back in. And the other thing as well is, if you look at the Republic of Ireland, if I live in Armagh, if I move 10 mile up the road, statistically my length of life expectancy for me would increase by 4 years, and for my husband would increase by up to 6 years. And yet they see their GP. On average, a patient sees a GP 9 times a year. If you spread that across all the population, allowing for people in the middle don't see their GP much at all in the middle of their lifestyle. But in the south, it's 3, and yet they have better outcomes.
Can I just?
Yeah, go ahead.
It's really important to look at new GPs who we're training. So we're training 121 GPs currently per year. They're trained excellently. They've got a 3-year training scheme. Yeah. In which I work, so I will say it's excellent, but by the end they're competent GPs who can deliver excellent care, and it's really important to say that during their training they are delivering fabulous care to our population as well. They're who you see when you go into the ED with your child, or you go to the fracture clinic, you have a baby. These doctors are all working in our hospitals and in our GP surgeries, so we want to keep them. Obviously here, 50% this year are international medical graduates who come into our scheme. They haven't qualified in the UK. So we need to work really hard to keep them here, because there are many reasons why they may wish to go elsewhere. They may wish to go to the Republic of Ireland. They may wish to go to other parts of the UK. So we need to be really good at keeping people here, and that's one worry that we have, that people are finding terms and conditions are better elsewhere, and they're moving with their feet perhaps because they don't have roots here, so they will put their roots down somewhere else, not too far away, but it could be here, if we could do better. The other thing I want to say though is that if you look at the number of people who are leaving the GP register, certainly the largest amount of people leaving are over 55s, but there is a concerning amount of people of the age between 25 and 35 leaving the GP register, and that really worries us because we are mostly working as self-employed, we're independent, there is no exit interview. Nobody comes to you and says, why are you leaving? You just leave. You go and get a job elsewhere. You maybe work, you maybe move to a position which is less, you feel it's less stressful. So this is not quantified. We don't really know how and what. We know why people are leaving, but we really need to try and keep the people who are working to stay.
Thank you very much. Thank you. Diane, for say.
Thank you very much, and thank you all for being here. You've definitely, explained things in a way that's given me a lot of food for thought and understanding some of the wider issues. I'm really concerned about the increased employers' national insurance contributions, and whenever this was announced by the Labour government back in October, a lot of people thought of businesses, and obviously they're in crisis. But I've been particularly concerned about the impact on public services. So over the past 4 months, we've done a lot of work and identified that for core departments and NDPBs here, there's going to be a recurring additional cost of £200 million a year. Treasury haven't committed to funding any of it yet, but there's an expectation in June there's going to be about 2/3 of it funded. But on top of that, I was pushing again further, and I've got the figures through from the Department of Health that they're saying for independent providers, for GPs, dentists, community pharmacies and the like, it's an extra £35 million they estimate every year for these costs. And obviously, because this sits outside of the core element that they're fighting for a Treasury contribution towards, it's sitting almost on a separate line. And I just wanted to ask you, do you feel that where you're already saying you're significantly underfunded to deliver these contracts, facing this significant additional cost coming from April, will this have a huge impact on the ground immediately in terms of access to GPs?
It will close some practices.
There will be contract handbacks without a doubt, because practices are already very financially precarious. I think it's important to note that practices can't, you can't go over budget. We can't do that. There's nobody coming to bail out an independent contractor practice. The bailout is the contract goes back, and you either suffer the financial risk and consequences of that, or that contract gets taken on by someone else. So the national insurance increases could be catastrophic if not met, because that's money in, money out. Even if that money comes in via the contract, there's no additional benefit to general practice. There's no extra services provided as a result of that money going in. It is money in and money out back to the Treasury, but it has the potential to destroy a lot of practices financially. And I'm going to bring it very slightly back to, so you'll be aware of the mixed model of general practice delivery now. So about 4 or 5 years ago, up until about then, we were wholly independent contractor in Northern Ireland, unlike the rest of the UK, where there was mixed models of health boards running practices, private providers running practices and the like. And now in Northern Ireland we have trust run practices, and that's where a contract has gone back and there's been no contractor and the trust has been asked to take it on, or these CIC, so Federation based CIC run contracts, they are all salaried doctors. So the salaried, or the NIC bill for those practices, the CIC practices, I can't speak to the trust practices because I don't know if the trusts are exempt and whether that will work, but certainly they're already facing significant overheads and increased cost in running a salaried service. And if every member of the delivery team is salaried, the NIC contributions for those practices will be to the point where they won't be able to function. The cost would be, I think you're probably looking at somewhere in the region of £130,000 across 8 practices. That will put those practices under financially, and that's not talking about independent contractors like ourselves. And we're all sitting thinking, we have huge figures to meet if there is no mitigation, and that will either result in a contract handback or a financial restriction in services or access. That's the only way. We either have to stop employing people, and that will either be someone on the end of the phone or somebody delivering care with a patient in front of them. That will be the impact.
I think it's just no mechanism to note here at this juncture, because obviously this has happened since the report, but I think that it's a really important thing. Sorry.
Just to say that we are, of all the independent contractors, we are the only one that have no mechanism of earning any additional money outside what we make through the contract. We can't sell more glasses, we can't sell more cosmetics. We can't do more private dental work. So we have absolutely no mechanism, because we're not allowed to charge our own patients for anything other than things that like HGVs and stuff like that, but nothing else.
I was going to ask around access for patients, but I just take on board your point there, Francis, about access for patients. You listed a lot of different things I maybe hadn't thought of, in terms of access. But do you feel there's anything that GPs could do to improve access for patients?
We can do more if we get more GPs and more people to help, more nurses and MDT staff. We will definitely deliver more, but we can't deliver more with less. I think the 10 million consultations or 200,000 a week demonstrates that we are doing in fact, statistically, we are doing a lot more. And it's not sustainable. It just isn't sustainable.
I appreciate that, thank you. And just my final question. The Audit Office reports pointed to just a greater continued reliance on non-face-to-face appointments here in Northern Ireland, in England, since the COVID pandemic. And I know you had mentioned it before, you talked about half of appointments, but it was just in the report they had at March 2023, they were saying Northern Ireland was 45% compared to 70% in England at the same juncture. So I just wanted to ask, why is this?
We're up now to 57%.
Still quite behind England, so just why
but
the
England
difference?
have other mechanisms. This is where the mixed model comes in. So the walk-in centres and different things like that in England we have no access to. We have the GP-only model here in Northern Ireland, so there isn't anything else. The other thing you've got to remember is not every patient wants a face-to-face. You know, any patient who asks me for a face-to-face will get a face-to-face, but not every patient wants it. You know, sometimes you're nearly round with them going, no, but I actually want to sound your chest. No, just give me an antibiotic. No, I really want to sound your chest. Please come in.
I think it's also really important to think about what that actually means in terms of face-to-face versus telephone versus whatever. So, pre-pandemic, you may or may not be aware that there was a huge push for GP practices to move to telephone first, and this was in sort of 2017. And there was a particular type of GP phone first access that was being pushed onto GP practices to say, look, this will actually create more access. Will you move that way? And as a practice, we were always, sort of pre-bookable appointments. We thought we'd pretty good access. And we said, no, we don't want to do that. And when the pandemic hit and we had this flip to phone first in the first instance, and we moved from that sort of not seeing too many patients because there was a need to try and limit, contact right the way up to where we are now, we would never go back to fully face-to-face appointments. And that's because I can see more people doing it the way I do it at the moment, and I can see them in a more timely way. So my lists are longer, because I can see a proportion of them or deal with them, a proportion of them by telephone, and that's what they want. And I can also prioritise. So if you're on my list in the morning as a telephone with something which I see that's been care navigated through to me and is an emergency, I can prioritise your call and phone you at 9:02 rather than you be my extra at 12:15 when I'm running an hour late because of all the face-to-face appointments and you've had to take time off work to come and see me. So we've got to create a model that fits as many people as we possibly can, and Phone First actually probably helps us deliver that in a better way, or giving those options for patients. I think what we need to try and do is make sure that we fit those options for the people that need them most. So when you need a face-to-face, you can get it. When a telephone works best, you can get it. And actually, when digital, because often we're texting patients with information and we're having two-way conversations via text, and that works for other people too. So it's about making sure that we create an environment where the people who can access services in one way get them that way, and where you need to access it in another way, that's available to you as well.
Yeah, thank you.
Thank you, Dan. Okay, Colin Crawford.
Thanks, Chair, and thanks, panel, for your time today. I just want to go back to the handbacks of the contracts. We know that in 2022 to 23 there were 13 practices handed back or gave notice to hand back their contracts, and then 6 practices 23 to 24, and I have no doubt that was not an easy decision for any of those practices to make. So apart from the obvious, what other underlying issues or concerns or is making those GPs actually to be driven to the stage where they're handing back?
And I say when a GP hands back, it is exceedingly distressing for the GP. And also remember, they're losing their contact with their staff as well. We have had GPs very conflicted and probably should have handed back sooner, but then got to the point of no choice. 2 things that are big factors. One is funding, so if you have enough money to pay your staff and make a living out of it, and the other one then is, do you have enough doctors? And if you haven't got enough doctors, it doesn't matter how much funding you have, you're not going to survive. One of the handbacks in our area was a practice with 5,500 patients and 1 GP. Like, how the heck does 1 GP do that? It's not possible. And if you're single-handed, you don't have any holidays. You're not guaranteed any days off. You have to be there 5 days a week, every week. You know, so if you get down to where you have very little doctors, the stress just ramps right up. And if you have funding at that stage, it doesn't matter. It doesn't matter because you just can't stick it.
Can I just say here that, as Frances said in the start of her remarks, we're all patients too, and that's something I think to remember, that we all try and have to access our own GPs, often on a regular basis for ourselves or for family members, so we get it, we know, and we also hear from our patients. I mean, many patients per day tell me how many times they've tried to get through on the phone, and that really affects us because we are sitting in the community. We're right in the, we're in the, we're beside your homes. We're right in your community, and we are the front door. Even though it's hard to get to us at times, we are there. We're visible, and it really does cause us significant anxiety. And like at least 40% of GPs feel that they can't cope at least once or twice per week. I mean, so that's a frightening statistic for me. And in the UK, it's supposed that every week one nurse dies by suicide, and a doctor dies by suicide every 3 weeks. So when we talk about burnout, it's real. It happens a lot, and people are quietly quitting, and we don't know. So I think that's something we need to bear in mind also.
When it comes to contract handbacks, and Frances and Emma have talked about the really difficult and tough decisions that GPs make, I think one of the other challenges is that once that decision is made, then that has the potential to create the ripple effect in other practices, because if the contract gets taken on, that's fine, because we'll hopefully secure a workforce and there'll be a new group of doctors go in. But if it doesn't, and there's a risk of dispersal, or there's almost a forced allocation of patients, that potentially, if you're a practice already struggling, and we know 1/3 of practices have accessed support because they're in crisis, that has the potential to actually have a domino effect in a region, and that's one of the key areas that we need to really focus on. It's about helping support workforces in areas where it's hard to recruit, and I don't think we do that very well, because we have a single model for contracting, we have a single model for training GPs, and once they get spat out the other end, once they qualify or get their CCT, as we talk about it, there are few mechanisms to support recruitment, but probably not enough mechanisms to support recruitment in hard to recruit areas. And the hard to recruit areas is where you're seeing an increased number of contract handbacks, and they're border regions, and they're regions of high deprivation, and they are regions where historically we would often have trainees who would come there who perhaps are international medical graduates or who have come from the Republic of Ireland and have no intention of ever working in Northern Ireland. They're going back home to work, and we could create novel solutions to support recruitment and retention in areas where it's already hard to recruit, and they've done that in England, Scotland and Wales, and often there are sort of rural supplements or remote supplements or things that you could do to bring GPs to an area, because once you bring someone to an area and they set down roots and they see what a nice place it is to work, they're more likely to stay. We have a very small GP fellowship scheme in comparison to the rest of the UK, which is at the moment in a pilot area in the southern area, in hard to recruit areas and places where there's a significant number of contracts going back, and it's designed to try and support recruitment into an area, but also support career development for early career GPs, because we know that if you can do that, if you can support them in the first few years out of training, you're much more likely for those GPs to take up substantive posts. So there are creative things that could be done to support recruitment in areas where it's hard to recruit. The other thing that's really important to note is that in areas of high deprivation and inequality, there are fewer GPs per head of population. So we need to actually tweak the funding model, which supports additional funding into areas where the need is greater, because the funding model that we have at the moment is not fit for purpose on that. So there are things that could be done to make it a bit easier, but it does need action, and we cannot get away from the fact that if there isn't investment, we will not let that happen, because even those salaried models that are happening at the moment, the CIC models, it's costing about 30% more to run those practices than it is an independent contractor model. And I don't think we can afford that long term. I think we've got to actually enhance the bit that works well, and that's independent contractor. We know Lord Darcy said in his report to the NHS was that, you know, GP has the greatest financial or fiscal awareness of all of the parts of the system. We need to enhance that.
That's great, thank you.
Thanks very much for that. I'm going to Colman briefly, but I'm just interested in a couple of things. You know, the closure of a GP practice is devastating, particularly, well, in any community, but it has a very direct effect in rural communities because it's often very difficult to pick them up. And the Western Trust, particularly in my own constituency, West Tyrone, has suffered in the past. Just to follow up on a question, and any of you could take this. When a practice closes, we obviously know the knock-on effect of that because you very clearly articulated it. But what is the implication of the trust taking over that practice?
Well, there's 3 different models. So there's what we call the independent contractor status. So that's where it's run as a business. Then you have the trust taking over a practice, and that's where they have a salaried model. And we're struggling to get figures from the trust and SPPG on how much it's costing. But looking at what they're getting paid as locums, we suspect it's astronomical. And as well as that, Kieran will tell you better because he is involved with the CIC. The CIC is costing more. It's a salaried model as well, and you cost more and get less.
Yeah, that's about what Ursula was mentioning. You're talking about 30%, at least 30% more to run these practices. And I suppose the difference with the trust and the CIC coming in, CIC has a very clear 3-year plan to try and make the practice attractive again, to recruit independent contractor status. So a lot of the early practices, they are now coming to the end of that 3 years. And if core funding isn't addressed, those CIC practices will struggle as well. To answer your question, Chair, in terms of the trust piece is essentially where there are staff in a practice that can continue to work, they will move over onto the trust. And then ultimately where GPs may have been partners in that practice, they may be offered salaried work within that trust, or they may leave. And ultimately the trust then has to recruit, simple as that.
And this is the critical question.
Yeah.
Offered a salary, a higher level than previously received?
Hard to know.
Yeah, we don't.
You're not clear on those figures. My concern here is that if when things are tough, clearly as you have outlined, if when things get tough and practices ultimately through very difficult decisions have to close, is there a risk that trusts taking over these practices actually incentivise, and use that word loosely, the closure of these practices?
Absolutely.
We could be
the domino effect that Ursula was talking about earlier.
Similar to the locum challenge.
Yes.
If a trust takes over a contract, or any contractor takes over a contract, I mean, they are duty bound to fulfil the contract, which means provide services for patients. And to do that, you have to do that in an open market. And one of the struggles with practices around a trust-run contract is that they can't recruit locums. They can't actually stabilise their own practice because there are, sort of higher fees for working in a trust-run practice. And we don't even know how many salaried doctors work in trust-run practices. We think there's lots of locums, and we know there are lots of locums, but we don't know how many. But yes, I mean, if the practice next door to me closes and gets taken over by the trust, and I look and think, gosh, they're doing that kind of work for that kind of money, and I'm absolutely, knocking it out of the park every single day. I'm, 2 minutes from burnout. Why on earth would I do what I'm doing when they're doing what they're doing? I'll just hand my contract back too, and we'll end up having a service which costs infinitely more.
So this would give me particular concern, and I'm sure other members as well. Typically, unfortunately, I'll use the Western Trust as an example. Locally, if this happened in the Western Trust, what the Trust actually thinks is a solution is creating a wider problem, and that is caused because the Department of Health will not properly fund GP practices. Is that an accurate enough?
The trusts are being charged by the department to take on the practice when there's no alternative. Yeah.
Creating a larger problem potentially down the road.
Potentially, yes.
And I suspect if you ask the trust, they will say, we'd really rather not, thank you very much, but we've been told we have to. Yep. So it's it's through no fault of them, and they have to provide a service. I mean, every citizen in this country needs access to GP service, and that's part of where they are. They are caught between a rock and a hard place.
It just looks typically like a stick and plaster approach instead of a solution. And ultimately, if we dealt with the problems we face around these issues, we wouldn't have to have the stick and plaster. So I really appreciate your honesty. David, Colin wanted in briefly, and then we'll go to David Honeyford.
Well, I'll wait till I come back in. The moment has kind of passed in the sense, so I'll come back to it and let David go ahead in his order.
No bother. Thank you, guys, for coming in. It's a difficult listen, actually, for what's happening, and we get it from the other side in the constituency. It's difficult for our constituents to get access to health, not just the GP, whether that's waiting lists or whatever. But as primary services kind of change, and you touched there about handbacks and that sort of thing, do we need to actually start again and look at new model of how this is delivered?
No.
Fund the model we've got.
I mean, the evidence is there. The independent contractor model has the best financial discipline of the entire health service. It delivers more for the money that goes into it, and the returns are there. So the other models that are being used are more expensive. I'm not sure of any other model anywhere in the world that actually delivers the same amount of benefit as a well-resourced and a well, with a workforce in an independent contractor setting. We have so much buy-in. GPs live and breathe their practices every single day of the week. We create flexibility for patients, and actually we can deliver in our communities what they actually need. So there will be a variation across the board. So what happens in my practice will be different to a practice in West Belfast, because the needs of the patients are different, and I can make that decision and they can make their decision to deliver for their patients within the confines of the contract, but actually be able to have a bit of flexibility. I think other models would create a degree of inflexibility and would cost more. So I would challenge that. Do we need to look for something else? No, we just need to make sure that what we have, the bits of what we have that aren't broke, that we don't break it even more, and that we actually fix the bits that have broken over the last decade.
It's a bit like you don't know what you've got until it's gone.
Yeah.
And it's not going to be too long before we're all gone if we keep going the rate we're going.
So just to clarify that, and I'm not suggesting, I'm just trying to tease out as you speak, and should we be looking at something else? But if you were starting from scratch and we were starting tomorrow and we didn't have GPs today and we had GPs tomorrow and you had a blank sheet of paper, is the model that we have now exactly what you would put down in that page as the business plan and design?
If it's properly resourced and you put a primary care team around core general practice provision, yes, that would be the best model.
Right. Okay. Yeah. No, that's really fully answered. Yeah. Thank you.
Do you want to now or go on to
Padraig? No, keep going.
Okay, Padraig's joining us remotely. Okay, Padraig, can you hear and see us? Okay.
I can, Chair. Just checking you can see and hear me. Okay. Yeah.
Perfect. Yep.
Okay. Thanks very much for your presentation, and like many others, you've probably answered a lot of my questions already. Your really detailed presentations and your responses as well. So, look, thanks very much for that. I suppose my question, and it's just if you can provide any additional detail on it, was just around, I suppose, the department's commitment to both build and retain existing GP workforce, and then what more can be done. I appreciate that's generic in the context of what you've said, but I do have just a follow-up point or two as well, Chair.
Yes.
So, I mean, when we think about the existing workforce, we released a strategy document last year, building a workforce fit for the future, which was, I suppose, a series of 17 recommendations that would create short to medium term stability. And as I said, it needed to be read in the context of needing additional investment and a proper workforce plan for the future, but this was to keep the folk that we have in place now. And we went across the entire country and spoke to GPs from every stage of their career and in every area, and asked them what it was that would keep them in their role and what would make them go. And of those 17 recommendations, they were basically fixed on essentially workforce and workload. So there is a huge issue around workforce, and we've talked about that quite significantly, but the GP workload is huge, and I know Emma has talked about the implications for burnout and what's happening, but there are things that could happen in a workload space that would make a difference. So we do a lot of work that isn't ours, that belongs to another part of the system, but comes to us because we're the most accessible part of the system and we're the part of the system that patients see. So there's huge amounts of work that probably need to be done in a secondary care setting but end up on our desk. And if that could be taken from us, that would make our day so much easier. We wouldn't be having a 12-hour day rather than, or we would have an 8-hour day rather than a 12-hour day. There's also aspects of digitisation. So a huge amount of what we do is still sitting in the past. So we've got this lovely Encompass service IT system that's working across secondary care that doesn't really interface with our systems, but actually what we really needed and what we would really like to see would be the introduction of electronic prescribing. Yeah. It would shave probably 60 minutes off my day and allow me to see 6 more patients. You know, that's the kind of thing that GPs talked about in terms of workload. But workload is directly related to the number of GPs and the number of the practice team, and that's directly related to the amount of funding that comes in. So workforce and workload are inextricably linked, but actually in order to keep people in their job, we need to make sure that terms and conditions for people working here are similar to elsewhere on these islands, and that's a hugely important thing. And also we need to make sure that those GPs who are in their jobs are not burning out. So we talked about that, and then I know one of the things that we are very keen to ensure is that for those GPs and those practice members of the team who are struggling, as Emma has talked about, that there are things in place to support them. So we're the only area on these islands that doesn't have what's called a practitioner health programme. So for GPs and clinical members of the team who are struggling with mental health and other problems, we don't have access to a dedicated programme that every other clinician, every other doctor across these islands has. And we need to make sure that we actually we keep well the people in our system that are keeping our population well. So those is just a flavour of them, but we can certainly furnish you with the whole strategy around retention of the GP workforce, if that would be helpful.
And e-prescribing, we can't underestimate the benefit of e-prescribing. We spend hours every day, and you know the days you're in work because you come home with a green finger, you know, pushing the scripts to sign them. Sign scripts up to this high, and you're trying to do that, make sure that the scripts are correct and they're safe. And then that bit of green paper gets lifted by a patient or sent to the chemist, or the chemist delivers it out, and there's bits of green paper going all around the system. And that could all be abolished by having e-prescribing. E-prescribing has been present in England for years. The technology's there, and they switched it on overnight in the south when COVID hit. So, and now they're telling us that, well, we're hoping for 2034 was the last estimate we got. Yeah.
I think with respect to e-prescribing, and with the way we work, we really have to have a commitment to sustainability, and that's a major issue in e-prescribing. There are vans driving around bringing prescriptions from my practice to a pharmacy, and it, I mean, never speak of the paper and all the consumables, so it's really important that we get that forward.
Mm-hmm. I think those are very practical suggestions, and I mean, definitely your suggestion of sending on, you know, any other reviews or any other suggestions in writing, I think would be very welcome, because I suppose one of the things that we need to do from this is to distill all that information, but also to be asking really specific and targeted questions of the department to ask how this can be done better. One of the areas that I'm particularly interested in is around the contracts, and you've obviously delved into that quite a bit already. But I suppose when we've talked about contracts, it's quite often been about contracts being handed back, you know, around that kind of crisis management and crisis support for contracts. I'm really interested in the other end of it, in terms of the access for GPs, I suppose, to take on a contract, and what support's in place at that end. Like, is there any sort of, I suppose, obviously there's a financial implication there. Is there any financial support to allow people to take on management of a practice? Is there any mentorship programs to do that? What support is there to actually encourage people to take on?
Yeah, if you apply for a practice that has been handed back for talk's sake, then you, if you're successful in that contract, there is a 3-year programme of additional support, and it's couched in the number, so many pound per patient per year, but that is withdrawn after 3 years. What the CIC practices are doing is they're trying to support partners that are already there, or new partners that are coming in to the 7 practices that they have. And this is the 3-year programme they have. Is they've experienced GPs and experienced practice managers going into those practices, building them up, giving support, and making sure that the doctors that are there are transitioned from being salaried into the position of actually taking the practice over and running with it, because it can be very daunting. It's not just seeing the patients, it's all that other stuff we have on the iceberg. And as well as that, you're also a business manager, and you're also have to run a HR department. You have to, look for your staff and ensure your staff are correct terms and conditions and all. It is quite daunting, but there are some support out there. Where it can be difficult is if you have, let's say, an experienced member, a GP, who maybe comes or retires, but they've been doing all the business management, and they retire. You sometimes can see that younger GPs can then panic and think, oh, I can't do this, and that sometimes leads to a practice closure as well.
So one of the things that's important, and we mentioned it in our strategy, is the GP fellowship programme, and I mentioned it before. That is a 2-year or could be a 2-year programme which supports that degree of career development that you've just talked about, Padraig. But so I think it's about trying to ensure that not only are GPs equipped to see the patients, but they're also equipped to be that manager, to deliver that service, and to actually support that business development, and be the employer and set the direction. And those kind of programmes would support that. We know that our GP trainees currently in Northern Ireland, the vast majority of them want to stay here, and the vast majority of them would be open to the option of a GP partnership within 3 to 5 years of qualifying. They don't want to walk into partnership, and by all means they are not equipped to do that, but we could do things that would enhance their ability and support them to take up those posts. I just think we're not doing enough of them.
Incentivise them, yeah.
Yeah.
And I suppose that's really what I'm getting at here. I mean, from your responses, it's clear that there are potentials there to change that. It's clear that you have ideas on how that should be done, and strategies on how that should be done. But obviously that there are many kind of strands to that as well. And I suppose, would it be fair to say, firstly, that what's there at the minute doesn't suffice, and then secondly, what other, some of the things that you've talked about, some of the incentives and the strategies that could be put in place. So one of them is given better support. One of them's, that mentorship piece. Is there anything else that can actually increase the opportunity for people to take on partnerships?
I think
Funding.
It comes back to the core funding issue that we talk about, because the model that whenever we were coming into practice would have been the job's attractive, you had more senior members when you were coming through as a trainee, you maybe got locum shifts within that practice, you got to know all the different aspects of practice management alongside the evolution of, say, practice managers coming into practices now. So if that model starts to deteriorate because of the lack of the ability to address core funding, then ultimately you can incentivise left, right and centre. It will not be enough. You will just move to a salaried model, which will be trust and maybe federation delivered, and it will be much more inefficient. So that it comes down to core funding. It comes down to young GPs coming into a practice, seeing the raft of experience that's there across the piece, whether it be the clinical piece and the management piece and the business piece. But that if that core funding model isn't there to support that, then the young GPs will not be attracted to it.
I think we also need to look at the narrative surrounding general practice, because it is negative. Whatever you see on social media, on mainstream media,
like being a politician.
I think we're all in the same boat, so we get it. But you also understand then how demoralising it is when you open up your social media and you see the job that you are spending. Hours per day. So a GP day is accepted now as 12 hours. That is standard. So a GP working, so days are split up into sessions, half a day is a session. It's accepted that a 6-session week is a full time. So that's 36 hours, practically your 37 and a half hours of a standard week. So, we have to try and address the public narrative, because that is most certainly putting young GPs off and coming into substantive posts also.
And that's not counting the hours you do at night on the computer, doing your bloods and your letters and whatever else.
I think it'd be really interesting, and obviously there's multiple elements to this, but they actually pull all that together, and maybe 4 or 5 specific asks that we could put back, and obviously that's probably on ourselves as committee. But maybe even a further engagement piece, Chair, that we can do with yourselves, maybe whether that's a follow-up in writing or something. I just think that the more specific we are on this, the better. in terms of actually getting the actions in place. So look, thanks very much, and your answers have been really comprehensive throughout, and they've really helped us get a better understanding. So thank you.
All right, to summarise it, national insurance, indemnity, and my 80 million, please.
Plus the 17 asks that we have on a retention strategy. We're not asking much.
I just started with the 80 million, but it's grand as long as it's out there. One of the key frustrations for me as a public representative for almost 10 years has been how they're very slow to implement change, and we complain that we can't afford to do the things that we're doing but don't affect any change. The stick and plaster approach to most things and how government works here. But there's a significant investment happening with Encompass. I don't know if you have looked at it in any great detail. But when we're talking about the electronic prescribing, have you explored if there's an option there for it to be built in, again, like a bolt-on, as Colin said earlier, to that particular system?
So I sit on a working group that is tasked with this. It was the progress towards electronic prescribing, and that's not really an option. So electronic prescribing will sit within a primary care setting rather than a secondary care setting, and Encompass is largely a secondary care IT system, and what we use in primary care is very different. The other challenge with an e-prescribing system is it needs to work both in general practice and potentially elsewhere across the system, but let's just talk about general practice because that's where most prescribing happens, and also in community pharmacy. So it needs to be the same system that sits within both because it has to go from one to another. So there are lots of different models across the world. Obviously the one that Francis talked about in England is up and running. It's something that could be lifted and shifted, absolutely. There are challenges with around procurement, around funding, and around the timeline, which are the big issues. But there are other models elsewhere which are being explored. I think the challenge for us is that it's been on the agenda. Well, it's been on the agenda for the last 10 years, and now it looks like it's on the agenda for the next 10. So again, when we come back to this whole aspect of demoralisation and what value is placed on general practice within the system. So we see all of the lovely new IT stuff that's going into secondary care. We see all the money going elsewhere, and we're sitting with our 5.4% thinking nobody really values us. Nobody really thinks it's worth investing in general practice. And it's just that kind of perception that both the public see but also the GP see. There are fixes. I think the big challenge are that most of these fixes require money, and that's the big barrier to e-prescribing being implemented.
The cost of not doing it is greater.
It's huge.
That's
huge.
important. We always have to, in this place, come back to that fact, the cost of not acting. Invest to save is a term that's used quite a bit. It doesn't happen quite a bit up here.
Well, 14 pounds return for every £1.
Yeah. So, Emma, did someone say earlier it's a decade before they say this system could be brought in?
2034.
So if that was the case, given how technology is advancing by the day in today's world, it would be out of date by the time it comes into measure. We'd be using AI to order prescriptions. So it's just unacceptable, the pace of how things operate here. And that's where the wastage is happening, and that is why there isn't proper investment in the services that we're talking about today, which you have very clearly articulated the problems around. The next question, Cahill's waiting patiently, and Cahill's coming on line as well. Cahill Boylan.
Thanks very much, Chair, and could I thank the presentees for the presentation. Very, very comprehensive. And Francis, I do apologise. You're up from the beautiful constituency of Newry and Armagh. I couldn't be there today in person, but I just like my colleague who asked the questions previous. I mean, for us to formulate recommendations at the end of this, I want to be trying to get to be succinct and specific in terms of the answers, if I may, and I'll try and narrow it down. So, Francis, to yourself, obviously, I know you mentioned different percentages there, but my question, because we know that funding in the north here has been traditionally lower than anywhere else in the UK. So my question is, what level of investment is needed in order to sustain and build general practice?
As I say, the 80 million is what we need this year coming in, and then that's 1% of the total budget, and then we try to move to a minimum of 10%, which historically it was. Back in England, Scotland and Wales are asking for 15%, and the 15% would allow you, over and above the 10, would allow you to bring more care into the community.
So the 1% going to be reported, is that the £40 per
Well, it's the same thing, £40 per
Same
patient by 2 million
is
is still 80 million.
100%, because I mean, like I said, it's for us to get a better understanding, because you give very comprehensive briefings and nearly answered all the questions, but I just want to get in my own head for reference once we go to do the recommendations. There's an increase in the number of private GPs practices. What impact is that having on access? But more importantly, what impact is having those who can't afford it?
Exactly, it's the people who can't afford it, and it's also it's a variable service in that we provide access to everyone. Some of the private GPs provide access only in certain areas, for example, maybe in family planning or in joint injections or some of the stuff we love doing. And it's easy, but if you get a complicated mental health patient in, they're not going to go private. They're coming to us. If you get a frail elderly person who now has maybe got 4 or 5 chronic conditions, they're going to come to us. So it is providing some access, but some of the access is the low-hanging fruit. We're still getting all the complicated conditions and the complicated, and it should be, because they don't have access to any of their medical record in the private, just what the patients tell them. And we have a particular problem with online prescribing from private GPs, particularly from England, and they're prescribing patients, like the weight loss jabs is one of them, and then we're getting a letter to say, by the way, your patient has got this. We would like you to check that the patient doesn't have a list of 20 things. So where am I going to get time? And if I do think it's been prescribed inappropriately, we had an instance where we believed it to be prescribed inappropriately against the indications, and said, well, we really need to go back and let this company know, and they refused consent to allow us to go back to let the company know. So it can provide difficult relationships between daytime general practice, especially in that area of prescriptions.
Okay,
Cal, what I would say
yeah.
about that is that it's another symptom of the issues that we've been articulating. So our patients wouldn't need to turn to private GPs if there was capacity in the system for us to be able to see them on the NHS. And it goes back to the comment I made right at the very start about what it is that we as GPs want. And the other side of that is that the more and more of these services that are available, I mean, private GP is a concept that has only sprung up in the last couple of years. When we all qualified as GPs, no GPs worked privately. Hospital consultants, absolutely, but you went into general practice in the knowledge that you would only ever be an NHS GP, because that's what we did here. And now we've got a shift, and one which I think we will struggle to pull back on, because those early career GPs that Emma has talked about, all the challenges and all the negativity, they look at it and think, actually, I could set up a private service here and I could see all the really easy stuff and it'll be really easy pickings, and actually I'll make a really good amount of money out of this. Why would I bother to go into an NHS setting where I'm going to be worked 12 hours on a full day shift and come home with all of those challenges swimming about in my head, with all those really complex patients, and holding all of that risk that we do? Because the other thing that's really important to remember, the amount of risk that NHS GPs carry is inordinate. And that's because of the volume of patients that we see, the complexity, and they are undifferentiated. Every person who comes through my door could have anything and everything, and I need to be able to handle that. So we carry a huge amount of risk, and our colleagues in the private sector, it is a very different model of service delivery, and the more we underfund NHS general practice, the more our patients are putting their hands in their pockets and they're funding private general practice. They're making up the shortfall from their own pocket.
Yeah, and the other thing, when we talk about carrying risk, one of the other things that we haven't really touched on is the waiting lists. And if I'm sitting in front of somebody and I'm saying to him, you're 60 or you're 70, I'm referring you for your hip, and they'll say, how long will that take? Well, it'll probably be 5 years for you to be seen, and another 5 to 7 years to get your hip. But that patient, when we refer them, until they're seen in 5 years' time, the risk still is with us. They're not actually a patient of the consultant. They don't get allocated a named consultant until very shortly before their actual appointment. So we're carrying all that risk of that person getting more frail, that person needing increased medication, that person being in severe pain. And one of my patients last week, actually, joked with me and he said, I know I'm on the waiting list for my hip, and I'll probably never get it, but that's the one benefit of falling and breaking my hip. I got it done.
I've written a bit more hips and knees in West Tyrone than I can count.
Well, just one final point, Chair, because just Francis, in the report there it says obviously clearly GPs are reducing their working days and obviously leaving the profession. If I said to you 3 or 4 key points to why that's happening, just bullet points.
Yeah, well, the working day bit is we're not actually reducing our working day. Our working day is 12 hours, so 3 days, and by the time you do your paperwork at home, that is more than full time. It's impossible to do 5 12-hour days. It's just not possible. So it is recognised. If you add up the hours, that is ordinary full time. If you look at a salaried model, a salaried GP will only work 37 and a half hours at most.
Right. So what you're saying to me is the model's there and it's working as long as it's properly funded. That's the gist of what you're saying.
Yeah.
Correct.
Yeah. Thank you very much, Chair. Thank you for.
I think, Cathal, just to supplement that briefly, to be fair, when you compare to how other jurisdictions are being funded, it very clearly points to a disparity here and a problem. Whilst there's problems in other areas, ours seems to be worse, maybe.
Well, Chair, yeah, just let me in there for a moment. This is why we're doing the inquiry. So, I mean, Chair, we're just trying to ascertain the problems and the challenges. So, I think there's been a good session so far. Thank you, Chair, for letting me in.
Okay. Cheryl Brownlee.
Thank you, Chair, and thank you so much. This genuinely has been really, really insightful for all of us, I think, so I really appreciate your time. You touched there with Cathal's question just in terms of risk and safety of patients, and I just want to give you the opportunity. You've talked about the workforce, you've talked about the extreme pressure on staff, you've talked about the workload increasing. How do you think that this is actually impacting patient safety and risk?
So if you've got a patient on a red flag waiting list that waits months to be seen, that's just one example. I mean, we could sit here for the next 6 hours and give you examples, but when you talk to a GP who's almost in tears because they're referring a patient who can't afford to go privately, and they know that the patient in front of them has cancer, and they know they're not going to be seen, and when they do get seen, their cancer will have progressed to the point where actually what would have been a good outcome is now a bad outcome. That's what we are dealing with every single day. And that's not talking about the people that, if you could get in there early, it would make such a difference. We're really good at doing preventive care. We're really good at doing proactive things. And we're also really good at the whole person. But when we're firefighting every single day and the patient that comes in and you've got 20 more to see, you can't give them what they need. So we're trying to almost ration what we have for the people that need it, knowing that there's a huge amount of need out there that's not being met, and that's the thing that I think plays on all of the GPs' minds. That's what contributes to the burnout, knowing that you potentially missed something, or that when you do pick it up it's not going to be actioned. And I talk to GPs who've moved south and they've said the reason I've moved to work in the Republic is that when I refer somebody they get seen and sorted. And I know I'm doing a good job and they come back to me and we've got the outcome that we needed. That doesn't happen here. We refer patients and we know they're probably never going to be seen if it's a routine thing. We don't have routine care here anymore. I can take a child who's 4 years old needing a tonsillectomy and refer them to ENT, and they'll be out of primary school before they get surgery. That's what we're dealing with. And that's why our workload is so huge. If we're seeing patients again and again and again and again, if you could take that away from us, we would have a lot more access to be able to deliver for our patients. But it's the impact of that, and it's the impact on patients, because it's soul destroying. I work in a region where someone can come in to me and say, I've got a problem, and the next thing they'll say, and I've got private health insurance, doctor. And part of me thinks, thank goodness for that. And the other part of me thinks, what about all those people out there who don't have that, who can't put their hand in their pocket, or who are going into debt? And that, when you get that day out, day in, day out, it really does have an impact on the care that you can deliver for patients.
And the other thing about that is, if you're referring somebody for their hip, there is a way to skip part of the waiting list. You can pay privately for the initial consultation and then get put on the NHS waiting list of the doctor that sees you privately. It's ironic now that one of our large private hospitals in Belfast has a payment plan with the credit union. That's shocking. I only found that out the other day. People are going into debt. People are saying to their families, I don't want birthday presents or Christmas presents. I want to be able to that £200-300 to go and see the consultant. And at least I'm skipping the first 4 or 5 years. It's absolutely soul destroying for the patients and for us.
On the ground, I'm seeing more and more of that. And, you know, the message continually in the public domain is, you know, look after your health. But when people can't get access to it, they will, if they can afford it, pay for whatever they can to get it and get access to it. And equally, I think amongst people we mentioned, those who are paying national insurance and their taxes, they feel they're not getting their fair share and ultimately are going on alternative routes. It's just a symptom of the whole system just falling on itself, simply because the system is not solution focused. It's sticking plaster approaches continually, which is deeply frustrating generally. The scenarios are, that you've said earlier about the hips and knees and everything else, there isn't a week in my office that I know of multiple people of a certain generation coming to me asking me to write to the trust in relation to it. And it is very, very frustrating. When there was the cross-border scheme, it alleviated some of the pressure and it gave people a lease of life. But I have seen people's health and well-being worsen because by the time they get one hip fixed, the other hip, because of all the strain, is in the same problem. So it's affecting the quality of life.
I think if we think about the focus of this session, which is access, so those same patients are asking us to write the letters to expedite their appointments and their surgery. And while they wait, they continue to come through our doors with, a lot of it could be just anxiety about the wait, but a lot of it will be actually progression of symptoms. They actually will become sicker. It's as simple as that. And that impacts then dramatically on access. So it's we talk about revolving door patients, and it's because we know what they need, they're not getting what they need, and then the impact on access and primary care as well.
And they develop other conditions because of their, you know, they're not able to move, they're not able to exercise, their physical and their mental health suffers. We are sometimes being forced into prescribing pain relieving drugs, patches that the patient otherwise wouldn't need. There are all sorts of issues with those. You see patients on multiple medications. The vast bulk of them are sorting out a problem that has been caused by another medication that you're given, and these people are potentially having to go on antidepressants, which is another issue because we don't have the access that we need to counselling and therapies in the community. So, the ripple effect is massive.
No, thank you, Chair. And I don't think there's a day that goes by when as MLAs, we don't get those types of complaints and concerns, and it's horrific. And whenever you say your health is your wealth, you know, at no point should financial bank balance ever being taken into consideration. You should be able to get seen and should be able to get that support at the time of need, and we're in a situation where that is clearly not the case anymore, and it's it's horrific actually. I just want to touch on as well, which is, we spoke about the long hospital waiting lists as well, and just how that is impacting on primary care.
So we talked about obviously the impact on the workload that we have, and I suppose one of the aspects, and I'm going to turn it maybe a little bit positively because there's been a lot of negativity, but actually there is a scheme in general practice that deals with very routine things that can be dealt with in general practice by using GPs who are upskilled in certain areas, and that GP elective care service has been one way to try and reduce waiting lists in secondary care, and also actually in a way stop patients getting referred in the first place. It's been a very successful scheme, albeit it's been funding to it has been cut, and it's a scheme which as GPs we would like to see rolled out more, and to develop further pathways where we could see patients. And this is again about this bringing care closer to the community. If you've got a community hub that can deliver for patients so they don't need to go to hospital, that's bound to be much better. It's also much more cost effective. So I'll give you an example. The vasectomy service in the general practice elective care system delivers vasectomies across the region. Prior to the service being introduced, there was probably only about 50 vasectomies done in a 10-year period. I'm not sure those numbers are not true, but a very small number. But in actual fact, those vasectomies were costing 3 times more than they cost in primary care. So you've got a service which has been developed with GPs, upskilling, developing special interests, an area that we know our early career GPs want to do. They want a special interest, they want a portfolio, they want to be able to do something more than those GMS services. But that service now delivers cost-effective vasectomies in communities for patients, and they deliver across a range of options like women's health, musculoskeletal medicine, dermatology, and a few others. But it's one example of where, and I talked about the flexibility and the innovation that happens in general practice. We want to make sure that the system works, and this is one way that we can actually deliver for patients. We can do those sort of more straightforward procedures by upskilling GPs, and we can do them more cost effectively in a community setting. And if we can actually upskill our workforce, it will keep them in their roles here because they see that as an attractive option. So that's just one, I suppose, positive aspect in terms of the waiting list, because I know we talked about the negative side of the waiting list and all of those patients coming back. Those hubs also create or reduce health inequalities as well, because we know that some of those, the need that is met in communities, and people are, it's much more easily accessible to come to a local GP practice than maybe perhaps have to travel, miles and miles to a hospital for something that you don't need to be in a hospital for. So that's just one example.
The other thing is a bit ironic as well. So one of the services was for women's health, and we're the only one of the 4 nations, including the Republic of Ireland, who don't have a women's health strategy. So some people, the great and the good, went across to look at England because they've got these women's hubs in England, and they're running really well, and they're taking a lot of care out of the hospital. And whenever they said, well, where did you get the idea? Oh, Northern Ireland, we got the idea in Northern Ireland, and we have defunded it and have no women's strategy. It's ridiculous.
Thank you.
You'd be a good politician.
Yeah, I was going to say. No, thank you very much for that. Just a wee small thing. Just the last session we had there, one of the words that kind of struck me was communication. And you have really opened my eyes today how you have been affected at the coalface. You're dealing with this day and daily, and really the figures and the statistics and the data that you've presented to me has allowed me to look at this in a totally different way. Yeah. So I just want to ask, in terms of the department, do you feel that they are supporting you? Do you feel that they are actually telling your story, how you're basically dealing with this situation at the coalface, and are they actually educating patients to make sure that patients have the knowledge and the understanding where to go to, how that communication happens, and what options there are? And particularly in terms of access, you listed a number of ways you can access GPs. I didn't think of that, and that's one of the key points as well. We are getting fantastic service. We just don't realise it sometimes as well.
And the iceberg, I think, is a really good way of demonstrating that. The short answer to the question is no, we don't feel supported. We don't feel that our story is being told. And that's evidenced by the fact that people are still saying, oh, GPs are closed and they're not seeing face to face. If we could try and get rid of that myth. The other way the department can support us is bid for funding. So last year in the monitoring round, June monitoring round, 120 million came to health. How much came to primary care? Not 1 penny. And we can't bid for it as individual GPs. We are dependent on SPPG, part of the department, to bid for that funding on our behalf. So not 1p.
And you're at the cold face.
I think GPs feel devalued by that, and it kind of just feeds that narrative. So if we feel that the system doesn't value us, and we all put value, everyone describes value in terms of monetary value, and 5.4% of the budget speaks volumes, and that's the value that the system puts on general practice. And if that's the value that gets put on us, then here's where we are.
Appreciate that. Thank you, Chair.
Thank you very much, Cheryl. Okay, Colin Gildernew.
Yeah, so thanks, and an awful lot of information there, and an awful lot of issues that I recognised from my previous role in terms of the Health Committee Chair. And I absolutely fundamentally agree with your comments early on around the shift left and the potential of that. I think far too often we talk about transformation in terms of hospital transformation and secondary care only. Yeah. And I think there's huge potential around primary care, community care, putting more assets out into the community. I also recognise the issue around, you mentioned the population increase, and that's not only just population increase as a problem, but also the fact that people are older, and there's more complexity, and the waiting list issue that Cheryl touched upon. When I left social work in 2017 in an older person's team, our workload numerically year on year was increasing 5 or 6% with no increase for staffing, and there's a similar dynamic going on within GP practice. I think we also could do more around the changing profile of GPs, in that there's many more younger women who are, as you have touched upon, not prepared to work or don't want to work all of the sessions in GP, and I think there's much more work to be done there. Probably a whole other report as well, but I absolutely recognise that. And the negative narrative, I do think, needs to be challenged, absolutely. And I think actually there's potentially a bit of a negative narrative within medical training as well, where GPs kind of, and that probably needs challenge as well. I welcome that McGee Medical School model where we're taking in older, maybe more rooted graduate entries into GP, and I hope all of that helps. My question, however, given time, I'll just go straight to that, is how essential is the development of MDTs, the multidisciplinary teams? So that's for the public, the physios, the OTs, all of those, the social workers who had been previously mentioned. How essential are those, the implementation of MDTs, to removing or reducing pressure or assisting you in delivering your service?
Yes, it is a very important part. And at the minute it is contributing to the inequity, and I think the words patchy were used earlier. It's contributing to that, but you've got to remember that behind that, all of our professional colleagues are fantastic and work really well, but they're not used to working without autonomously. So there's a level of supervision that's required by the GPs, and they need to come back to the GPs to query things. So if you don't have enough GPs, you can't implement the MDT model. It's not possible, because you need GPs on the ground to work with these colleagues, and then it works. I just want to make a point as well. It's not just women who work six sessions a week. My male partners and do exactly the same.
Well, absolutely understand. What I'm saying is recognising that we have many more younger women who are maybe starting families who simply can't commit to that level of work. Are we doing enough in terms of flexibility in the contracts we're offering? And also related to that, the issue you also touched upon around them not wanting to necessarily run a business. So is there more that can be done?
I don't think it's about want. I think it's about facilitating and supporting. So, I mean, as I say, when we ask our early career GPs, they do want to be GP partners, and they do want to do that within a 3 to 5 year time frame. And that doesn't matter whether they're male or female. There are 3 female partners sitting in front of you, and we are, and we all have families. So it's we have to make sure that we don't go down that rabbit hole of, well, we've got an increase in female population of GPs working, and we need to make sure that we do that. I think we just need to make the playing field a level one for GPs, and we need to make sure that we're resourced enough to support them in their career. That is probably a bigger and a wider question for another time. I'm going to come back to MDT though, if you don't mind, and because I think we do recognise that having a wider practice team is better for patients, and having care in the community is better for patients, and there is a stabilising factor there in the short term from an MDT perspective. And this is speaking from a GP. You'll probably be one of the last to get an MDT, because where I work, we're the bottom of the list. And what I will say is that the inequity for the patients in my practice versus the ones who live 4 miles down the road and are registered in a practice that has an MDT and has had one for the last 4 years or 5 years, it's hard to actually, fathom that patients are having a huge inequity of access. But what Francis talked about, that core general practice, that is vital. And I'm going to just, and I know that these figures are out there, and I think the Audit Office figures for the amount of GMS funding in the year 22-23 was 375 million. And that's for GMS services across the region. A fully rolled out MDT, I think, is going to cost somewhere in the region of 116 million. And that's to add on 1 whole-time equivalent mental health worker, 1 whole-time equivalent physiotherapist, and 1 whole-time equivalent social worker for every 10,000 patients. So I think we need to be careful about making sure that there is a proportionate funding for the delivery of service in a community setting. So I think MDTs are really important, and I would welcome a faster and a more equitable rollout. But I think I need to make the case for we cannot do that at the expense of general practice.
Final brief one for
You're
me, just on that is, and you had said early on as well when you were asked by the chair if you had more money, what would you do with it? You'd said investing in staff, and related to both the core GP staff and the MDT staff. If you had the money right now, do the staff exist, and is there enough been done in terms of that workforce planning?
So I know there are issues around training and staff availability around those MDT roles, and I know that there has been an announcement, or potentially there will, in order to staff an MDT, you need to train those people. But I think we, and from a general practice perspective, would say that we need to increase the number of GP trainees that we have. We need to increase that workforce. We need to increase that pipeline, because we are losing GPs and we need to replace them, and we need to make sure that we've got more for that ageing population that you talked about. If I had more money tomorrow, would I put it in MDT or put it in core GP? I'd probably put it in core GP, because I think we are at the risk of hugely destabilising the service at all. And you talked about hospital reconfiguration and where we need to go. I mean, again, it's an old saying, it is the foundation of the health service that we are sitting on and that we are delivering, and that foundation is really, really unstable. There are cracks in this foundation that people probably don't comprehend, and we need to make sure that we actually shore that up and we stabilise that. And MDTs is a level, is a way of doing that, but you cannot put an MDT around a practice that doesn't exist.
Yeah, and the other thing, that's why we're asking for the funding incrementally. So we're not asking for the 10% all at once, because we recognise we couldn't spend that all at once. But if you give it to us 1% year on year, we will definitely bolster up general practice. We'll get more people in. We will come up with ideas on how to keep our trainees and look at the different schemes that are available. That's what the money is going to be used to do.
And also, just to say very briefly, I thought I had a fairly strong commitment from the previous health minister around the indemnity issue, so I am disappointed to hear that hasn't made more progress at this point. Shouldn't miss it.
I agree with you, and we'll be chasing that up.
There is an offer out to us at the minute on indemnity, but on its own we can't give that to the profession to decide whether it's enough, because we need indemnity, NIC and core. On its own, the offer for indemnity is not enough. We need the others as well.
One brief thing, Chair, just to say on the record.
You've been very patient with us, Colin,
we talked about the cross-border scheme. It is worth remembering. A number of years ago, we also lost access to the entire European, and that's a huge loss.
Yeah,
and that has never been as a result of Brexit.
You have been great witnesses and been with us for 2 hours or so now, so we really, really appreciate your time.
Looking at us.
The presentations were very hard-hitting. The answers to your questions were very blunt and very honest, and they've put shape on where things are from our perspective. I think I speak for the committee in that regard. Knowledge is power, and we've learned today things that we did not know. I was just reading a headline there. You're talking about 80 million, and it sounds like a lot of money when you say it out loud, but when it comes to fixing something as essential and vital as local GP services, it is very, very little in terms of a starting point. And there was a headline recently, it was around December time, I was just found it there. PPE worth 80 million bought during COVID pandemic could end up in Northern Ireland landfill. We do so much so badly, and there's things that we could fix and do well. And I've heard constituents for countless years complain about access to GPs and everything else. What you have told us today is a very different story, but one that each of us have a role to play in as well, because we have a responsibility to challenge the narrative, to support our GPs as well as our patients, and to challenge the Department of Health to step up and start doing more. Just over 5% of funding is not adequate when you compare it across the board, and I think today your very honest answers to our questions reflect that. And I picked up on a point. I was going to ask it, but I think Cheryl asked it. Do you feel supported? I knew from the outset of today's presentation that you don't feel supported. And that is very difficult for GPs doing an extremely challenging job. Often similar, actually, to politicians a wee bit. We never hear about the good we do, just about the bad. And I think it is important that this Assembly, and certainly the Department of Health, get a handle on this. You're not asking for the mountain. You're just asking for a bit of help to get things back on in the right direction. So I really appreciate your honesty. You've made this session quite straightforward for us. We've got a lot out of it. I'm sure the Controller and Auditor General and the Northern Ireland Audit Office team would agree, and Stuart and Julie as well. Have you anything further you would like to say before I invite further comments?
Other than to thank you for giving us this opportunity, and to thank you for allowing us to be plain speaking and take on board what we have to say. We want to provide better access for everybody, and we can do it if we are funded.
Let us do our job is what you're asking, I think, is the fairest way of putting it.
And I think just that we want what patients want,
yes.
Which is what all of us want. And I think, you know, it's important that, I suppose, with all that negative narrative, that people understand that, you know, even though you think we're not working or we're not doing what we're supposed to be doing, that's exactly what we want. We want to be able to deliver a good quality service, because that will keep us all well and healthy into the future.
Okay. Doreen, have you anything you'd like to add? You're happy? We've covered a lot. Stuart?
No comments from us, Chair.
Stuart, you're very quiet today.
Given some of the severity of the comments around monitoring rounds and so on, it's challenging for public expenditure and for the department to face up to the realities of some of those items. I think that's what all I can say.
Change is needed. Invest to save.
Yeah.
Again, I just want to thank you on behalf of the Public Accounts Committee for being with us, for taking time out of your busy schedules, for travelling some distance as well, and for being with us. We've heard you loud and clear. I can give you that full assurance, and I just want to thank you again.
Thank you very much.
Thank you very much for all this.
Okay, members, we now move into closed session.
Senate Chamber. Sound. Senate Chamber. Sound. Senate Chamber. Sound. Senate